Hi everybody. So now we begin with radiology. So this is my subject and this is what, I think I can teach you at maximum capability, even though, I enjoy teaching a lot of other subjects more than radio just because of the repetitive nature. But, radio will always be my first love. So that is what we will focus on. It's such a wonderful subject which is read in the most incorrect manner by most students. It is very, very conceptual. Radio is something where, the images tell you so much and every image is different. So you can't memorize anything, because every patient, every X-ray is a different X-ray. You can't memorize X-rays ki ye image hai, so that is what you have to learn here is to apply. So that's what my effort is to not help you memorize signs and create mnemonics, not here. This is where we understand each and every point that you don't really have to revise radio again. You watch this video once or twice, understand what patterns we are looking for and then apply. So it's all about understanding. So give this a watch. In fact, this is one of the subjects where you can just watch passively, understand, watch it twice or thrice. Don't make any notes, it's fine. Very few facts that I'll be telling you. Wherever there are facts, you remember, but most of these are going to be concepts, right? So the first thing that you want to understand are three topics we are going to cover here. One is radiology core, then you have nuclear medicine, and then you have radiotherapy. Nuclear medicine, radiotherapy are two different MD branches, they're different branches altogether, but we club them because their importance is not much and they are allied to radiology. So we'll cover them in the latter half. So my first focus, all right, for the majority of this talk is going to be radio. In radiology, we deal with essentially 4 investigations. So let's talk about these investigations and then we add on to that. So we have X-ray, CT, MR and ultrasound. And then we have nuclear medicine as a separate diagnostic branch, right? So let's talk about how each of these, differ and how these have evolved. So the electromagnetic spectrum, you have X-rays as a part of it, you have gamma rays as part of it. So when I use the X-rays, I make them pass through the body and they, go to the image receptor, whatever they have passed through. Suppose my body, which has bone, which has lungs, everything is going to attenuate the X-ray separately. Attenuate means it will absorb and the resultant X-ray that reaches the image receptor behind me will be different for each of the structures that it passes through. So that's what we are seeing, that when it passes through lung, the image appears black. When it passes through bone, the image appears white. So that attenuation being the buzzword, is what we are converting to black and white. So that is what is the most basic thing, that is X-ray. So this is where the rays are passing two-dimensionally through me, right? So X-ray, I'm sure all of you have seen X-rays in your life, is a two-dimensional investigation, and the concept is on attenuation of rays, and this attenuation is different by different structures. So this is done in a two-dimensional manner. If the same thing, same attenuation, now you do it in a three-dimensional manner, meaning now the rays pass through me in a 360-degree manner. What does that mean? That means now I can take axial cuts, right? Axial cuts as in, imagine making slices of your body and you are visualizing each and every slice. So what do we call slice in a fancy way? We call it tomo, right? So that is why CT stands for computed tomography. We are collecting slices of the body. At each plane I pass the X-rays and then I collect the bunch of slices. Do you agree? I have a full 3D volume of data. Now what can I do? I can make coronal, I can make sagittal, I can make axial. So that makes CT a three-dimensional investigation, and because this is done using computer, obviously this is computed tomography, right? So the only difference is this is 2D, this is 3D. So that means what is black on X-ray is going to be black on CT, what is white on X-ray is white on CT. Can I also say that wherever X-ray is my initial investigation of choice, CT would be the best investigation for those conditions, right? Because CT shows me the same thing with much higher resolution in a 3D. So that's what we have to understand as far as X-ray and CT go, that they're essentially the same. CT is just a better version of X-rays, a 3D version of X-rays. So can I say that both of them have ionizing radiation? Yes, they do. Then we talk about MRI, fancy stuff. So what is MRI? MRI stands for magnetic resonance imaging. So what do these words mean? I can only understand imaging out of this. What is magnet and resonance? One more thing. The concept is one more three-letter word that's called NMR. What does NMR stand for? So NMR stands for nuclear magnetic resonance. So this is more or less the same words, right? We can see magnetic resonance is common to both. Now nucleus has come. So what is the concept here? See, you all know we are 60% water, right? Our 60% body weight is water. Now water has protons, right? H plus ions. These protons are all spinning on their own axis. So they're spinning. Imagine this is the axis of a proton and it's spinning. Whenever a charged particle spins on its own axis, it generates a magnetic field. So that means we are all made up of bunch of tiny magnets. Yeah. So are we all magnetic? Like some of us have magnetic personalities, but we are not literally magnetic. Why not? Because some of these are rotating like this. Some of these are rotating in the opposite axis. So the net magnetic vector becomes 0. Right? But now when I place this person with tiny magnets in a huge magnet, so the machine of MRI is a huge magnet. You must have read 1.5 Tesla, 3 Tesla, right? So that's the strength of the magnet of the machine that you're placing this patient in. So now what happens? Now if this is the axis of the external magnetic field, our body's protons also align in that direction. And there is resonance. You know, resonance is when the frequency matches. So both of their frequency matches, and that's how we generate a signal out of it. So can you see how fancy it is? You know, I did not use any electromagnetic radiation, nothing. I used body's own magnetic field and I made a signal, I made an image. So does it have ionizing radiation? No, it does not. So that's one of the major benefits of MRI, that it does not have ionizing radiation. And you know what? This has, out of all the investigations, the best contrast resolution. Means if I have a doubt and I cannot see it on any other investigation, MRI will show me for sure. So that is why when I want to do brain imaging, spine imaging, I would prefer MR. The only drawback is it takes time consuming. It takes around 30 minutes minimum to get an MRI image done, right? So that is the only problem. Plus it's expensive. It's not readily available. So those are solvable problems, but time unsolvable. So that is one of the major drawbacks. And that's why, you know, let's say somebody has a stroke. MRI is the best theoretically, but practically not possible, because doing MRI only takes away 30 minutes, right? Your time is ticking away. So that's why that's the drawback, that you cannot use it for emergencies. But let's say I have a tumor, I want to characterize it well. What will I go to? Always MRI, right? So that's the general concept. We'll build upon this, but this like conceptual understanding of investigations is very important, because then you take informed guesses. All of these questions on initial investigation, best investigation, next best investigation can all be solved only conceptually, not by memorizing, because I change one word and your answer changes, right? So that's what is important. So this is MR for you, no radiation, best resolution. Then we have ultrasound. As the name suggests, ultrasound, it uses sound waves but in an ultrasonic range, what I cannot hear. So the ultrasound sound waves are 2 to 20 megahertz, right? So these are the sound waves that I'm using in the ultrasonic range, which is 2 to 20 megahertz, and that is why I cannot hear it. What do? The sound waves go through the body. Again, depending on whether it's reflected, it's absorbed, we will see different colors. So is there any radiation? Absolutely not. There is no radiation. Again, I'm just using sound waves. Now, how do I make sound waves go through my body? Right now, I'm speaking. The sound waves are not going inside your body and getting reflected. It is getting reflected from your brain. That's a different thing, but it's not going inside. So what does that mean? That means I need to convert it into mechanical energy. And how is that done? So that is basically piezoelectric crystals. So what I do here is, first, this is what the crystal is, which is present in the ultrasound transducer. You must have heard this term transducer. We'll do a question on the types of transducers, right? So this is transducer. That's the probe that will be kept on the patient's body. So what these have are these crystals, which are made up of lead, zirconate, titanate. Okay, so that is something you don't want to remember. Why? Because it's in the name, PZT, right? So it's in the question itself. So these crystals, you know what they do? Transducer literally means something that converts different energies. So we are passing electricity through this probe. That electricity, makes these crystals vibrate, meaning it makes it into mechanical energy. This mechanical energy is then converted to sound waves, and it is these sound waves which go through the body. So this transducer converts the mechanical energy of the vibration of crystals to sound waves, and that is what is then perceived, whether it's reflected or not. So it comes back as sound waves, makes the crystals vibrate, and then I see an image. So that's how ultrasound works, and all of this process, it's just sound waves, no ionizing radiation. So that's one of the biggest strengths of ultrasound, again, that it does not have ionizing radiation. And then what is the other advantage? It is the only investigations out of the 4, X-ray, CT, MR, it is the only one which is real time. Means I can keep the probe and I can keep seeing movement if there is any, right? So this is what is a real time investigation. But that also means that the one who is holding the probe must know what they are doing, right? It's not like X-ray, CT, MR that the machine has taken an image and you can show it to as many people as you want. You will have to do the ultrasound in order to see, right? So that is why the problem here becomes that it is operator dependent. So it is operator dependent. So that's ultrasound. Please don't write all of these things, just understand so that you don't forget. All right. Now, let's talk about black and white. So, out of these 4 investigations, if we see something dark or if we see something bright, we have different terms. It's not good to call somebody black or white on their face, right? So, we don't do that to lesions also. So, we have fancy terms. Essentially, you're calling black and white, but in fancy terms. So, X-ray, anything which is black is what is going to be called as a lucent. Anything which is white is opacity, right? Everything else very easy. If it is black, we start with hypo. So you need not know the rest, right? If it is hypo, it's dark. If it is white, we're going to call it hyper. Okay, so that's simple. We change the suffix. So if it's CT, I'm going to call it hypodense, hyperdense. If it is MR, I'm going to call it hypointense, hyperintense. If it is ultrasound, because it's echoes of sound waves, it's hypoechoic, hyperechoic, right? So that makes sense. So all I read in the question is hypo or hyper and the problem is solved. So this is the basic gist of the 4 investigations that we need to know about. Now we start talking about nuclear medicine. Now, nuclear medicine is a whole different branch, right, which does not deal with X-rays. It also has one ionizing radiation, and that is gamma rays. So nuclear medicine is dealing with gamma rays. All right, so we will study nuclear medicine how we use gamma rays. Either in, there are 3 kinds of studies. Either in scintigraphy, which is a 2D counterpart of nuclear medicine, just like X-ray. If I add a CT to that, it becomes a 3D scintigraphy, which is called SPECT. At the outset only, you can remember SPECT stands for single photon emission computed tomography, and we have PET. PET scan is positron emission tomography, but all of them deal with gamma rays, right? If something is basically going to show uptake with either PET or SPECT, we can call it hotspot or we can call it avid, right? So if it is positive, we call it either PET avid or we say it's showing a hotspot, right? So these are 2 terms. Nothing for something which does not show uptake. That's not abnormal, right? And does it have ionizing radiation? Oh yes, it has the maximum ionizing radiation. So if I have to say out of all investigations, what has maximum? Anything that uses gamma rays will have maximum radiation. So we have something called as PET CT, right? So this is what we do, whole body PET CT for metastasis. I'm sure you've heard of it. So now imagine PET, very high radiation. CT, very high radiation, and you're combining them and doing it for the whole body. So obviously it's going to have the maximum radiation out of everything. So this is your fundamental building block. So now if we have to talk about numbers, not important for you to remember, but just see the context of how much radiation we get in every investigation. So for chest x-ray, it's the minimum. This is one number you may want to remember. So this is 0.02 millisieverts. You can see how it keeps increasing in different x-rays, mammographies, x-ray of the breast. So all of these, are higher radiation than chest x-ray. Look at CT. Just CT of the head is 2 millisieverts, right? So it is almost 100 times that of a chest x-ray. If we increase the volume of the body, for chest it becomes 5, for abdomen it becomes 10. PET in itself for the whole body is 10 to 12. So if I add up the CT for whole body, it's somewhere around 15. So that is why a whole body PET CT would have a radiation penalty of somewhere close to 25 millisievert, which is the maximum out of all investigations. And then we have these barium studies, which are 7 to 8, 2 to 3. So this is so high. So these are x-rays, but what I do in these investigations is I take multiple x-rays. It's almost like a video of x-ray which is playing, so many x-rays. So that's why the radiation is so much. So that's why we don't use these investigations a lot nowadays, because don't you agree that we can just do a CT in so much radiation? Might as well get 3D information. Why do bunch of x-rays? So that's why, these are all falling out of fashion, and we don't really do these anymore unless we have a very specific indication. So this is about the overall idea. Please don't memorize these numbers, just have an overall idea of how much the radiation is, right? So that's about the basic understanding. So now from this point onwards, all I'm going to do is show you multiple investigations and teach you the thumb rules. If you can understand this part, rest of the radiology is very, very breezy, very easy. So what we have to then do is learn where I will use what investigations. So rather than showing you a table of this condition, this investigation, we flip it. What we do is I'll show you the investigation and I'll tell you where all is this the best, right? So that way you understand the concept and you don't memorize it. So let's start off with X-ray and CT. We said both of them are essentially the same color gradient. So on an X-ray, first of all, this is an X-ray. For all investigations, let's finish right, left. You will always remember it's like somebody is opposite to you. So this is right, this is left, right? Somebody standing opposite to you. So this is my right, this is my left. So that's what you do in the X-ray. So always remember, whether it's X-ray or CT, what is right side? This is right, this is left. This will be true for X-ray, CT and MR. So that's the first thing. Then in chest X-ray, look at the different colors that you are seeing. Can you all appreciate how lung is black and bone is white? So on a X-ray, we see 5 densities only. What are the 5 densities? So we have air. So this is from black to white. So the blackest thing or the darkest thing is air. After air, you have fat, which you will see in the subcutaneous fat, right? So you can see here, this is black, right? So this is air, this is fat. Then you have soft tissue. On an X-ray, soft tissue or fluid, meaning your muscles, fluid, CSF, everything will appear the same. Blood is fluid. So soft tissue and fluid are the same. Then you have something white, which is bone, and the whitest of them is going to be a metal, right? So metal is the whitest. So we don't have metal normally in the body, but if there's a metallic foreign body, it's going to be whiter than the bones, right? So this is what you need to understand for radiographic densities. From black to white, we have these 5. CT, because it's better, the gradation is the same, but CT can distinguish soft tissue and fluid separately. So we will talk about that. But is this much clear? So now when I show you this CT, can you appreciate this bone is white? That's why it's a CT. That's the first rule. That bone white means CT. So that's done. Then you can see how the lung is black. Look at all of this soft tissue. Look at this muscle. So muscle and your fluid more or less are the same density here, right? So they can be distinguished, but more or less the same color of gray, right? That's what we learned in X-ray also. But now see what has happened. Suddenly I see that whatever had blood has become whiter. Why is that? It's because I've injected contrast. If I take an IV cannula, inject iodinated contrast, all of the blood vessels are going to become white. So that's what we are doing. So this is a non-contrast CT scan. This is a contrast enhanced CT scan. So this is where I'm putting IV contrast, right? So CECT will make all of the blood vessels white. So we will learn the anatomy, but I hope the difference is clear. So now will you all be able to recognize a CT? Yes, bone is white. Will you be able to recognize NCCT versus CCT? Yes, look at blood vessels. So always, you can look in front of the vertebra. There we will have the aorta. So if this aorta is white as the bone, you can say it's CCT. But if the aorta is just like the muscle, compare it with muscle and see, then it is NCCT, right? So that's done. Then we talk about the special type. You can see how lungs are black. So how will I make out pulmonary pathologies if it's so black? So that's why, again, it's a perspective shift. This is what we call as windowing. I'm changing the contrast such that everything else becomes white and the lungs are best seen. So this is not a different CT that I have to acquire, not a new one. I just changed the windowing. So this is what we call as lung window because I'm trying to see the lungs, or you can call it as HRCT. So this is HRCT lung, high resolution CT of the lung. So anything in the lung, pulmonary pathology, you will do HRCT, right? So that's what you have to remember here. So you can see pulmonary pathologies here. So this is a basic understanding. Next question which I want to address now is rib counting. How do we understand counting of the ribs? You frequently get questions from that. So look at this. First of all, understand ribs are like this. Means the anterior ribs are curved and the posterior ribs are horizontal, right? So what you have to look here is, can you see these curved ends? These are anterior, and can you make out these horizontal ones? These are posterior. So that's the first step. You will be able to say right and left. You will be able to say anterior, posterior. So let's say posterior. That's what is asked more commonly. You start counting posterior ribs from the first horizontal one that you start seeing, which is this one. Do you agree? So you start counting 1, 2, this is 3, 4, 5, 6, 7. Right? So that's what you do. But what you are not adding is one more rib which is there. So that's why whatever you have counted, you add +1 to it. Let's try. Let's say that I am pointing at this rib. So what do? Come on, do it. Pause the video and do it yourself first. So unpause and see. So you have 1, 2, 3, 4, 5 and 6 and you do +1. So can I say this is left 7th posterior rib? That's what you have to do for posterior ones. You count the horizontal ones and add 1 to it. That's done. For anterior ribs, the curved ones, you can see each and every one of them. So that's why don't really add anything. Can you see? This is the first rib. This is second. This is third. This is fourth. This is fifth. This is sixth. This is 7. This is 8. So these are the anterior curved ends. One more time I'll show you. 1, this is 2, this is 3, this is 4, 5, 6, right? So this is how we calculate anterior and posterior. For posterior, you add 1, for anterior, you don't. Alright, so now whatever black and white I've been saying, in CT scan, we describe it in terms of a number. That number is called as the Hounsfield unit. Alright, so it's Godfrey Hounsfield who discovered CT scan. So that's why that's called as Hounsfield unit. What I've done here is I've given distilled water a HU or Hounsfield unit of 0. So I need a reference, right? So whatever compared to distilled water is darker gets a negative HU. Whatever is whiter gets a positive HU. There are only two things darker than water. What did we see on X-ray? It's air, which is the darkest of them all, and fat. So only air and fat have a negative HU, will look black. Look at this CT scan. Can you see air is the blackest of them all? And now look at this image. Can you see the fat, subcutaneous fat? See, it's black. compared to muscle, right? And it is not as black as air. So both of these are negative HU. Distilled water I can't find in the body, right? It's a theoretical reference, but I can always look at this. This is the CSF. So you can always use this as your reference point to see if something is whiter than this or something is darker than this, right? So that's about it. What all are whiter? So you have soft tissue or muscles, which is almost the same. So you can see there is a subtle difference, but more or less same grayness with muscles. 60 to 90 is very important. Acute hemorrhage. So when I have an acute bleed in the body, that's white. So that forms the basis of head trauma imaging. For head trauma, if I have an acute bleed, it is always going to be hyperdense, right? So that's what you have to remember. And then you have iodinated contrast. We saw how contrast was white. So iodinated contrast is 100 to 300. And then you have bone. Something which is off the scale, not even in the scale because it's not in our body, would be metal. So metal goes off the scale. So this is the gradation. Water, soft tissue. Acute hemorrhage comes in. Iodinated contrast, bone and metal. So this is the range of Hounsfield units. Don't memorize the numbers, only remember air and fat are negative. So now that tells us that everything which is intrinsically hyperdense or white on a CT scan, do I need to give contrast? I don't, because then you are confusing yourself, right? That is it contrast which is white or is it the substance which is white? So that is why anything which is intrinsically white, I need not do CCT. So that is why NCCT is the investigation of choice for all of these. What all is white? Essentially, can I say bone is white because of calcium? So it's calcification, calculi and bone. And even in the bone, it's the cortex which is white, not the bone marrow, because bone marrow does not have calcium, right? So these three on the basis of it having calcium are white. Acute hemorrhage we saw was white and metal was whitest of them all. So for all of these as a cluster, we will do NCCT as the investigation of choice. Wonderful. So now when we talk about calcification, what do we need to remember? So can I say for intracranial calcification, any calcification, let's say I have calcified masses or brain tumor, so I will see NCCT. Any calcium I want to see anywhere, I'll do NCCT, non-contrast CT. So let's talk about patterns on torch. If I see this sort of white calcification, what is this? This is periventricular calcification. V is V. This is what we see in congenital CMV. But if I see the white dots here in the parenchyma, that is congenital toxo. There is one more. If I see it at gray matter, white matter, then that is Zika virus, right? So three torch infections show us calcification, CMV, toxo, Zika. Then, can I say calculi? All calculi are calcified except gallstones and CBD stones. So for all calculi, the investigation of choice will be NCCT. Whether I say renal stones, whether I say ureteric stones, whether I say salivary stones, the investigation of choice for all of them will be NCCT except gallstones, which are made up of either cholesterol pigment mixed, very rarely calcified, or CBD stones, which are essentially the same, just the site is different. So for both of these, we will not do NCCT. We will talk about them, but at the outset, you can remember gallstones, my investigation of choice is ultrasound. For CBD stones, my investigation of choice is MRCP. We will talk what they are, right? So this is about stones. So look at this. Can you diagnose where the stone is? Look for white. Can you see this? So how will you report this? You will say, ma'am, there is a left-sided ureteric calculus with, can you see how the kidney is swollen? With hydronephrosis. So that's all. You are reporting like a radiologist within 30 minutes of this video. Amazing. So this is calculi. Bone cortex. Can I say cortex? There are two pathologies. One is fracture. Fracture is a break of cortex. So for all fractures, initial investigation is always an X-ray. I don't need to tell you that. But if I don't see a fracture on X-ray or something like spine X-rays, which are very complex to be seen on X-ray, my investigation of choice would be NCCT. Except which kind of fracture? except stress fracture. So stress fracture is the only one where you may not have a cortical breach. All I will see is bone marrow edema. So that is why whenever I want to see bone marrow, MRI, cortex, CT. That's what you have to remember. So for stress fracture, investigation of choice becomes MRI, right? So that's one exception. Then we flip the story. For all bone tumors, tumors will involve the medulla, right? Bone marrow. So for tumors, my investigation of choice is always MRI, except one. So now it's the other way around, except osteoid osteoma. So osteoid osteoma is the only one which is a cortical tumor. So for that, NCCT is the investigation of choice. We learn bone tumors in ortho, right? So stress fracture, MRI, osteoid osteoma, NCCT. So look at this. Can you see how there is a spine fracture? This also we'll learn in ortho. When there is a through and through fracture, this is what we call as a chance fracture. So for spine fractures, we'll do NCCT. Then look at this. Can you see this is the cortex, this is the bone marrow. So this is what is a cortical lesion. There is a nidus. This is what we call as nidus, and this is osteoid osteoma. So if you remember these thumb rules, you are essentially doing just cluster of pathologies altogether. So you can answer any question, right? Then what did we say about acute hemorrhage? Where do you get acute hemorrhage? You get it in head trauma. So can I say for head trauma, any patient, the investigation of choice is NCCT. Why? Because look at this. I will see the hemorrhage as hyperdense. Can you see? So on the right side, this you might be knowing already from surgery itself. This is idly. So this is what is EDH, whereas when you see a crescentric hemorrhage, this is what is a subdural hematoma on the left side. But both of these are what? They are both acute hemorrhages because they are white. Had they been grey like the brain, it would have been chronic hemorrhage. So that's the learning point here. There is one exception again. This is diffuse axonal injury. So now diffuse axonal injury does not really lead to vascular injury. As the name suggests, there are axons which are breaking, right? So because there are axons breaking, that may not present as hyperdensity. So here the patient may have a GCS which is very low. They will say patient very severe accident, GC is very low, but CT kaisa hai? CT is normal. So when you see such a peculiar condition, you're like, okay, must not be bleed then, must be axons breaking. So how do I diagnose that? So for that again, I'll have to do MRI. So this is where again we do MRI and we'll talk about that. So this is the thumb rule for head trauma. Then metallic foreign body. So any metallic foreign body, can you see how brightly it's seen? So this is an intraocular foreign body. So this is where you have to remember any foreign body investigation of choice is NCCT, and even more important, what is it that you will never do is MR. Why? Because MRI is a magnet. It's a huge magnet, and if you put a metallic foreign body in that magnet, there will be impact, there will be trauma to the patient. So this is something which is detrimental to the patient. Don't do MRI, right? Where foreign body is suspected. So this is about the thumb rule. So let's do active recall of this page. What did we say? That if there is calcification, if there are calculi except gallstone and CBD stone, if there is cortex which is to be seen, so fracture except stress fracture, and all tumors are MRI except osteoid osteoma, where I'll do NCCT. So these were all NCCT. Then we talked about acute hemorrhage, so head trauma NCCT except diffuse axonal injury, and lastly metallic foreign body where MR is contraindicated, right? So that's done. On that lines only, let's study the approach to foreign bodies. Let's study all of these X-rays here. So now when we talk about foreign bodies, first question is, what is this and where is this, right? So look at these three. There is a radiopaque metallic foreign body. So whenever you see a round face, this is what is located in the esophagus. That's how you can write esophagus. So when you see the full profile of the foreign body, it's in the esophagus. But when you see it's a slit, it's in the airway or the trachea. So that's the first thing. Then look at the two images. Can you see how on the second image, there's actually a double line that we are seeing. So this is what is the double line sign, and this is what is indicative of this being a button battery. So you must have seen small button batteries. They are like this. So a child may swallow it, because it's there in toys. So button battery will, because it's three-dimensional, will show you two margins, because we are converting it on a two-dimensional image like X-ray, right? So that's why you see the two rims. But a coin is a flat object, more or less flat. So that's why you don't see the double margins. So when you see the two margins, it's a button battery, otherwise it's a coin, right? Which is more dangerous? Obviously a button battery. Why? Because button battery releases alkali, and alkali causes liquefactive necrosis, leads to perforation. That is why this has to be removed immediately, right? Because it can cause perforation. So the learning point is, if there is button battery, the answer would be remove it immediately, no matter where it is. But in coin, if you see that the coin has passed onto the stomach already, it is here or it's below that, then you can just do wait and watch. Because if something can pass cricopharynx, which is the narrowest point of the GI tract, it can do anything in life. It will come out in the stool, you get your coin back. Congratulations. But if it is not in the stomach, it is somewhere like this particular patient, it's stuck in the neck. Why? Because this is the level of cricopharynx. So it's stuck at the cricopharynx. So if it is proximal to stomach, I can say, then what do? Then you will have to do upper GI endoscopy and remove this coin. So if it is proximal, do upper GI endoscopy, remove it. But if it has reached stomach and distal, wait and watch. So this is what we have for esophageal foreign bodies. If it is in the airway, obviously I will have to do a bronchoscopy and remove it. So that is called rigid bronchoscopy. Flexible bronchoscopy is usually for biopsies, right, where we want to maneuver more distally. Rigid bronchoscopy is more therapeutic if you want to remove a foreign body. Now look at this image. I don't see any foreign body, but the history is very similar. In all of these, they will tell you one child was either playing alone or was playing with sibling, without adult supervision. So child playing alone, and the history will definitely stress on the fact that acute dysphagia is happening. So this is the same child who's also having acute dyspnea, was playing alone, but I don't see any coin. So does that mean it can't be foreign body? It can be, because most of the foreign bodies are not radiopaque. What if a child was eating a peanut and suddenly aspirated, because child may not be able to chew on the peanut, so he aspirated it. How will it look? It looks something like this. What are we seeing? Can you first of all see the X-ray and tell me what you think is the problem? Can you all appreciate how the left side seems blacker and larger than the right side? What would that represent? So think, if there is a foreign body which is not radiopaque and somebody aspirates it, let's say it goes into the bronchus, so something like a peanut, what will that do? It creates a ball valve effect, wherein air can go inside that lobe, but it's not able to come out. So that is what we call as air trapping, right? So that is called as air trapping, and this is why the left lung is blacker and larger, and that would suggest that the child has aspirated a foreign body in the left bronchus, right? So that's how we diagnose. We see the area that is blacker, all right? So that's what is air trapping. And do you agree this would be best seen on an expiratory X-ray? Why? So expiratory X-ray is better here. Normally all the chest X-ray we do are inspiration. Why? Because I want the lungs to be inflated. This is where I want the lungs to be whiter. Why? Because that will enhance the contrast between this lobe which is white and rest of the lungs, or the other side normal lung. They will become whiter in expiration, but this air trapping will become more predominant. So the difference between normal abnormal is exaggerated. So that's why this is the only place, where I'm going to do an expiratory chest X-ray, and then we'll learn one more. So two places. So this is one of the two places where we do expiratory radiograph. Then you have to remember, if there is a complete obstruction, what if there is a big foreign body? In that case, air is not even going inside. Then I will see collapse. So an aspirated foreign body can lead to two things. It can either lead to air trapping or it can lead to collapse. So we'll talk about collapse separately. But this is the approach to foreign body that you have to learn. Now we talk about some axial CTs to teach you the anatomy. First of all, can you all appreciate bone is white, so CT, vessels are white, so CCT. So we are looking at different axial cuts of CCT, and I'll take you through the different vertebral levels that we are cutting through also. Something similar we learn in anat also when we look through cadavers, right? So look at this. This white thing is thyroid. Why thyroid is white? Because it has iodine. You know, iodinated contrast is white, so that's why thyroid looks white. Okay, so this is what is the level of thyroid and trachea. This is black trachea, but I don't see the lungs. So where you don't see the lungs, this is cutting through T1 vertebral level. Then I don't have T2 image. There you will just see the apex of lung. So T2 vertebral level is where just the lung apex has started. Then you have T3, super important. Look at this. Can you see 3 vessels at T3? First of all, this is the trachea, identified through air. Behind the trachea also contains some air, is esophagus. Okay. Then I have 3 vessels. These are the 3 branches of aorta. Who are they? Remember, Budd-Chiari syndrome means brachiocephalic artery, common carotid artery of the left side, subclavian artery of the left side. BCS, Budd-Chiari syndrome. What are the vessels anterior to it? Are the brachiocephalic veins. So right and left brachiocephalic veins, which are soon going to merge below to form SVC, right? So where you see 5 vessels or see the 3 branches of aorta, it's T3. If I go one level down, I will see their parent, which is arch. So arch has how many letters? 4. So this is cutting through T4 level. We know also arch of aorta comes from 4th arch. So that's also done in terms of anat, pharyngeal arch. So this is T4. What is this? The 2 brachiocephalic veins have merged to form superior vena cava, and then this is trachea, this is esophagus. So T4 arch. Then T5 is the most important plane because everything divides here. This is our plane of SAM. What do I mean by SAM? So this is SVC, this is ascending aorta, and this is main pulmonary artery. So at this point, the arch is now divided into ascending and descending. Okay, pulmonary artery is dividing into right and left. And you can see even the trachea has divided into right and left main stem bronchus, and this is where I have collapsed esophagus. So T5 is the plane where everything divides. Ascending, descending, main pulmonary artery, trachea. So remember SAM, SVC, ascending, main. So what all did we do so far? T1, thyroid. T2, apex of lung. T3, Budd-Chiari syndrome. T4, arch of aorta. T5, everything divides, right? Now we are reaching the level of the heart. So this is the level of heart. First of all, in heart, you have to know what is the anterior most heart chamber, what is the posterior most heart chamber. So posterior most heart chamber is left atrium. Very, very important. That's why if I want to see left atrium very clearly, can I go through the esophagus? Yes, you can do a transesophageal echocardiography, and that shows you left atrium very clearly. Then the anterior most heart chamber, that is right ventricle. So if they say that somebody is stabbing you in the heart, like literally stabbing you in the heart, that means the first chamber that they will hit is right ventricle. Alright, so that is RV, this is LA. Then you can see on the right side, obviously one is left, which is right atrium, and whatever this is must be coming from left ventricle. So what is this? This is the aortic outflow tract. So this is where you are seeing all this. This is T6. Then you have T7 where you see the 4 chamber view. You can see all 4 chambers. So come on, how do we divide these chambers? How do we diagnose? Posterior most LA, सबसे आगे RV. If I know these two others are simple, has to be RA, has to be LV. Yeah, so this is how we do. So you label LARV and you are sorted, and this remains your descending aorta. You can also see two baby vessels beside aorta. Who is this? So on the right side, you know the azygos comes, on the left side hemiazygos comes, and these are gonna then drain into SVCs, which we learn in ANAT, right? So this is T7. Then we go to T8. 8. Remember ventricles like 8. So this is the two ventricular plane, RV and LV. So that's it. You need to learn the planes up till T8. Let's revise. T1 thyroid, T2 apex, T3 Budd-Chiari syndrome, T4 arch, T5 everything was dividing, T6 the aortic outflow was seen, T7 four chamber view, T8 ventricles. Right? Then let's talk about liver segments. So this will also learn in anatomy how we divide the liver segments. So we divide them on the basis of the hepatic veins, right? So we divide them horizontally on the basis of the hepatic veins. But vertically we divide on the basis of portal vein, right? So this is how we have the 8 segments of liver. So how we label them is 2, 3. Then you have 4A, 4B, and then you go clockwise 5, 6, 7 and 8. So this is how we have the different segments of liver. So these are the 8 segments of liver that we need to know about. So how do we name them? First of all, how to know whether I'm cutting upper or niche? Always look at the liver. If you can see this ligament, falciform ligament, black, means you are at the inferior segments. If you can't, look at this. If you can't see that, don't just look out for this, complete one. If you can't see that, then you are superior. Okay, so that's how you know whether you are looking at superior or inferior ones. So now, try to do this in your head. Upar ke char. So what are the upar ke char? So you have 2, 3. 4A, 4B, 5, 6, 7 and 8, right? So that's how in your head you will do. You will not memorize it. So you have 2, 3, 4A, 4B, 5 and 6. So this is what you have to do for segments of liver. Alright, so now if you tell me, ma'am, what is this vertebral level? For that, first I need to see this. Where you will see the IVC. Can you see this is IVC, this is aorta. In front of vertebra is always the aorta. On the right side is IVC. And what is entering the liver is portal vein, and this chotu baby is hepatic artery, right? So where you see the portal vein and IVC in one plane, you can see kidney has still not started. This you will say two parallel lines is T11. So this is T11 plane where you can see IVC portal vein. Remember like that. IVC portal vein 11. So that must mean this is either T9 or T10. So in T9 I see all together 3 things. Liver, lung and heart. All of them are cut at T9. I don't see everything here. So this must be T10. So this is T10. In T9 you will see 3 structures together. So forget about that. So this is T10 and this is T11. Now look at this. This is where you can see the renal hilum. Now renal hilum, you know, kidney is L1, L2, L3. So this corresponds to L2 plane. You can see here this is the pancreas uncinate process, the lowermost part of pancreas. I can recognize uncinate because it's related to superior mesenteric vessels. Now you remember smaller. Small means SMA is smaller and it is on the left side. So this is SMA, whereas the larger one is SMV. So remember small. So this is how you can figure out different planes and the anatomy. So I think this is very, very important for you to understand fundamentally. That's why I'm teaching you right now. So we have a closure on X-ray and CT. So now when we talk about MRI sequences, what is your fundamental starting point? Your fundamental starting point is World War II, means water is white on T2. So look at this. Can you see how the CSF is white here? The moment you see that, it is T2. So that's done. So that's the easiest one, right? That T2 means the water is white. So this is where the fluid is going to be white. Alright, then you see in this image that the CSF is dark. That immediately does not make it T1. For T1 weighted, what I have to see is gray matter, white matter. So can you see it follows the name? Gray matter is gray and white matter is white. Gray matter is darker than the white matter. So this is what you have to remember in T1. Gray matter, white matter follow their name and CSF is dark. Okay. So now look at this one. Here I can see that, okay, CSF is dark. Is it T1? Let me confirm. So I see that, oh, no, it is actually opposite. Gray matter is whiter than the white matter. So when it does not fit with T1, it must be T2. But then why in T2 is the CSF dark? So this is a special sequence where I take a T2 weighted image. Right? So this is what is called as FLAIR, fluid attenuated inversion recovery. So this is where, full form is not important, I've taken T2 and I have subtracted the CSF signal such that its essence is that of T2 only, but we made the CSF dark. Ma'am, why are you doing all this? I'm doing all this because, can I say first of all that any pathology, the hallmark of a pathology is its edema. It will be white on T2. Now imagine there is a periventricular edema. Do you agree this will miss that? But in FLAIR, where it is T2 but I have suppressed CSF, do you agree any pathology will just shine at me? I am not confused whether it's CSF or not. So that is why FLAIR becomes most sensitive for detecting pathology, isn't it? So this is most sensitive for pathology, particularly in conditions like multiple sclerosis. Look at this. Can you see periventricular edema? This is what we call as our Dawson fingers. Periventricular demyelination. So for Dawson fingers, multiple sclerosis, periventricular demyelination, FLAIR becomes my investigation of choice. Right? So try and fill this table now. Can I say T1, the fluid is dark. T2, World War II, water is white. In FLAIR, I will have to specify that, ma'am, CSF you have made dark, but any edema that exists will be white. So I'll be like, yes, you are very smart. Gray matter, white matter, can I say it follows the name in T1? Gray matter is gray and white matter is white. Perfect. So can I say it is ulta on T2? Ulta means opposite. So white and gray. Perfect. What about fat? Now look at fat. Can you see how fat is white in all three? So that means that fat is white on all T1, T2 FLAIR. It remains white. So that's a takeaway point. So this is about the brain sequences, T1, T2 FLAIR. Now, we said one statement, right, that for bone marrow, I want to do MRI. Why? Because CT, फिर से बोल रहा हूँ last part. For bone marrow, I want to do MRI. Now, which MRI sequence is your question? What is the problem I have? See, bone marrow contains yellow marrow. Yellow marrow is fat. We saw fat is white on T2. If there is bone marrow edema, that's also white on T2. So how will I know whether it's edema or it's fat? So that is why now I have to do the same strategy I did for FLAIR. Do you agree that, ma'am, you take T2, but now you subtract fat out of it, right? Such that whatever is the edema will be white. So this sequence is called STIR. It stands for short tau inversion recovery, but you don't want to do that. You remember STIR. Whenever I say any bone marrow edema that I want to see, our investigation of choice is MRI and the sequence is STIR sequence. Look at this femur. Can you see how it's dark? It's because I've suppressed the fat, and you can appreciate how this is white. And can you see a line going through it? That's the fracture. So what fracture would this be? Where there's no cortical breach. What did we learn? Yes, so this is stress fracture, where I don't see a breach. All I see is bone marrow edema and a fracture line going through the bone marrow, right? So this is what is STIR for bone marrow edema. This is our takeaway here. Then remember, head trauma, NCCT, except diffuse axonal injury. So diffuse axonal injury, we said, ma'am, please do MRI. So you are like, which sequence? So the sequence of choice for diffuse axonal injury is called SWI. SWI stands for susceptibility, weighted imaging. So susceptibility weighted imaging is going to detect each and every small micro bleed now, because wherever the axons are breaking, they're going to leave behind small bleeds. So that's what we are seeing here. We are detecting the small micro bleeds, right? So this is what is diffuse axonal injury. These black spots we call as blooming. All right, so we will talk about this more when we go to surgery and head trauma. So this is what you need to remember, that the sequence is SWI. Then let's talk stroke. So when we talk about acute stroke, remember in the beginning I told you that MR is best. It is very sensitive to pick up stroke, but it's very time consuming. I cannot do it in stroke. So that is why when we talk about acute stroke, you have to read the question very carefully. If they say what is it that you will do initial, or if they say what is the next best investigation, you will say I will do an NCCT. Why NCCT? Because I want to differentiate whether it's a hemorrhagic stroke or an ischemic stroke. You know, I can detect acute hemorrhage very well on NCCT. So if I see that, I say it's hemorrhage. If I don't see that, I say it's ischemic. So I use NCCT to rule out hemorrhage. But if they say what is best investigation, what is most sensitive investigation, then you will say it is MRI, right? So nothing can beat an MRI. Imagine you have a dedicated stroke hospital where you have 5 MRs, standing by. If a stroke patient comes, will you do MR? Yes, in that case, I will prefer to do an MR. But most of our hospitals are not dedicated stroke hospitals. So we end up doing a CT scan, right? So that's what you have to remember, that MRI is the best. And with sequence, that's diffusion weighted imaging. So as a macro view, to not confuse, you can remember this is cross mnemonic. What is cross mnemonic? D is S and S is D, so that you don't mix diffuse axonal injury with diffusion and stroke with SWI. Remember, S and D go together, right? So look at this diffusion weighted imaging. This is where you have this white thing and that becomes dark on this image. So essentially this is what diffusion weighted imaging looks like, and this is just a computer generated imaging called ADC. We don't care about ADC. But what we say, that something which is white on DWI and dark on ADC, this is what we refer to as showing diffusion restriction, right? What do I mean by diffusion restriction? So imagine this is what is a piece of tissue I'm imaging. These are the different cells, right? You know, water moves randomly. That's called Brownian motion. So normally the water is moving. I said no diffusion restriction. What is moving? Very good. But if I see that there's a tumor, multiple cells have come, do you think there will be a diffusion restriction? Yes, water can't move freely. What happens in stroke? Can I say there is cytotoxic edema? What do we mean by that? So what is the earliest part of cell injury we had studied? It's cellular swelling. When the sodium potassium ATP pump goes in stroke, that's the earliest cellular insult. What happens? You have intracellular edema, cellular swelling. So the cells have now become very big. Do you agree water can't diffuse freely? So that is why acute stroke shows us diffusion restriction. Third thing, what if I have complete pus in the cavity? Abscess. Abscess shows us diffusion restriction. And lastly, I have a cyst filled with keratin. That is called as epidermoid cyst. Keratin, even though it's a cyst, it's a collection, but it's not pani in the fluid. It is keratin. So that keratin is what is going to cause diffusion restriction. All right. So what all causes diffusion restriction is tumor, acute stroke, abscess and epidermoid cyst. So these are all the uses of diffusion restriction. Then you have this color. Suddenly, after 1.5 hours, I'm seeing color in radio. What is this? This is diffusion tensor imaging. This is what is to visualize white matter tracks. If I make a 3D graph out of this, we call it tractography. All right, so this is diffusion tensor imaging. We can see white matter color coded. This can be used, for neurosurgery, where I want to see whether the tumor is involving the white matter or not. I can use this for planning, surgeries in trauma, whether white matter disruption has happened or not. So these are the different sequences. So put a checklist, T1, T2 flare, stir, SWI, DWI, DTI. So these are the different MR sequences. Going to MR thumb rule, now we already know this. Can I say for anything in the brain, spine or nerves, because MRI has the best contrast resolution, if I have a tumor or a pathology involving any of the central peripheral nervous system, I am going to do MRI as the investigation of choice. So brain tumor, spinal trauma. If I have spinal cord trauma, what do we call that? That is called as scivora. Scivora is spinal cord injury without obvious radiographic abnormality. Means this happens in children. In children, they have such pliable bones that they do not get bony fractures, but you will see they have a spinal cord injury. So that is called scivora, happens in children. And can I say investigation of choice becomes MRI? Yeah, because I want to see spinal cord on MR, can't see it on CT. So that's what is important. Apart from that, the other application would be nerves, right? For lung tumors, what would be the investigation of choice? It would be CT, right? What did we say? HRCT for lungs. But is there an exception? Yes. What is this? So this was asked in November INI 25. Can you see how there is a mass in the superior aspect? This is what we call as Pancoast tumor. So Pancoast tumor is also called as superior sulcus tumor, right? So now this tumor has a tendency to cause Horner syndrome by affecting the sympathetic plexus, and it can also involve the brachial plexus, leading to weakness in arms. What do I do to see these? I will do MR. So this is the only lung tumor where MRI is the investigation of choice, right? Then you can also see an enhancing brain tumor. What did we say? For any brain tumor, MRI is investigation of choice. When you have such necrosis, when I give contrast, you can see center part is not enhancing, means it's dead tissue, necrotic tissue. This is where you suspect a high-grade glioma like a glioblastoma multiforme. So when the center part does not enhance, it's dead, it's necrotic, it's an aggressive tumor, right? So this is about brain, spine, nerves having MRI as investigation of choice. We've already established bone marrow edema, MRI. What are some conditions where I would see bone marrow edema? One is done. Stress fracture, investigation of choice, stir. Right? All of bone marrow edema, I do stir. Second, can I say acute osteomyelitis? My investigation of choice is MRI. Very, very important. Can I say all bone tumors, investigation of choice is MRI except osteoid osteoma? So this is what was asked in November INI 2025, where they gave osteomyelitis versus even sarcoma. What to do next? MRI to distinguish, right? And you can also see sacroiliitis. So we will study ankylosing spondylitis in ortho, right? Sacroiliitis is the earliest finding of Ang's point. Where will you detect it? MRI. This was asked. Look at this. So this part here is the sacrum and this is the iliac bone, right? Is that part clear? This was asked, but this is not sacroiliitis. Sacroiliitis would be restricted to here, right? What you are seeing here is a H sign. So this is May INI 2025. So this is where you can see a Honda sign, right? So this is what is called as Honda sign, and that indicates a sacral insufficiency fracture. Okay, so when you see it going through the body, it is an insufficiency or an osteoporotic fracture which has happened. This is not sacroiliitis. Sacroiliitis would be restricted to the two sides. So this is what stir and bone marrow edema on stir look like. Can I say any ligament, cartilage, soft tissue I want to see? Because MR has the best resolution, I will see. Very, very important. Knee, sports injuries. What is this ligament? You can see it's coming anteriorly. We've studied this in ortho also. This is ACL, anterior cruciate ligament. So any ligaments you want to see, MRI is the investigation of choice. If I ask you what is the gold standard, that's obviously arthroscopy, right? Because you can see also, you can treat also. That's called as gold standard. So this is what we need to know about MRI and the thumb rules. The last investigation that we need to do is ultrasound. So ultrasound, has sound waves, and we are going to see how different things behave. Two things very, very important. The first is gallstones. Look at this. This is the gallbladder, and within that, can you see something very white? Now, gallstones are very, very dense. What they do is they take all of the sound waves and either reflect it or absorb it, so much so that there's nothing left behind them. So that is what you can see as this shadow. So this is what we call as posterior acoustic shadowing. Means there is no sound wave which is left to go behind. So this is what is a property of calculus, right? Any calculus for that matter. But because gallstone was not visualized in any other investigation, particularly we use this for GB calculi, and that's why the investigation of choice for gallbladder stones was ultrasound. Are you understanding? Apart from that, can anything else show shadowing? Yes, bone can, because bone also is calcium, does not allow sound waves to go through it. And you can also remember air. Now, air does not cause this dense shadowing. We describe it as dirty shadow, meaning air does not allow the sound waves to pass through them. Means the air is going to refract the sound wave so badly that I can't see. So remember this fundamental rule. Air, enemy of ultrasound. Whenever I think air, I think X-ray CT. It looks black. No role of ultrasound. That is the takeaway here. That kabhi bhi air aata hai, don't think ultrasound. Right? So that's shadowing for you. Then look at this. Look at how black this lesion is. What did we call black ultrasound pay? We called it hypoechoic, but this is pitch black, no echo, not even hypo. So this is one step behind it. This is anechoic. It's black, and not just black. Look at this. It is allowing more sound waves to go through it. So this is very generous. It's like, I don't want, please go through me. So it is allowing all of the sound waves to go through it, resulting in this becoming more prominent. So what is this called? This is called as posterior acoustic enhancement. So when you have a lesion that is anechoic and shows posterior acoustic enhancement, we know it is made up of fluid, water. So you will remember this. Kala pani. Water is black on ultrasound. Wherever I want to see fluid, I will do ultrasound as the best investigation, always. So fluid or cyst, investigation of choice, ultrasound. Yeah. So can I say, if I want to see pleural effusion, I want to see pericardial effusion, I want to see ascites, I want to see hemoperitoneum, any fluid, investigation of choice, ultrasound. And that is what forms the basis for FAST. Yes, in surgery, in trauma, we have studied EFAST. FAST detects fluid. So you know the specific points where we put the probe. So it is extended focused assessment using sonography in trauma. So the focused point, let's say, is the hepatorenal pouch. You can see dark color here, black color here. That's fluid for you, right? So you can see this free fluid here, and this is what we call as EFAST positive. That's why we use ultrasound for fluid always. So that's the thumb rule, that kabhi bhi gallbladder dekhna hai, any GB pathology, you want to see pani, fluid, you will do ultrasound, right? So air, enemy of ultrasound, fluid, best friend of ultrasound. So that's the takeaway here. So now let's look at a few modifications of ultrasound, right? The first thing we are talking about is Doppler. So what do we mean by Doppler ultrasound? See, this is what is a blood vessel, right? This is our simple ultrasound. When I don't mention anything, it's a B mode ultrasound, brightness mode ultrasound. Now I turn on the Doppler and I see that the blood vessel shows color. Why is that? So that is because it's utilizing something called as Doppler shift. Okay, you must have studied this in class 11th or 12th. Doppler shift. Imagine I'm a stationary object here and an ambulance is coming towards me. Can I say, as the ambulance comes closer to me, the sound increases. As it goes away, the sound decreases. That is called Doppler shift. That when an object comes towards me, the frequency increases. When it goes, the frequency decreases. So that's what I am using. Imagine my probe now is the stationary object and blood is flowing towards the probe. high frequency. Blood is going away from the probe, low frequency, right? So that's what I am using as color coding, that anything which is a positive frequency shift, give it red color, because that would indicate that the blood is coming towards the probe. Positive frequency shift. Anything which is blue would indicate negative frequency shift, means ambulance is going away. So this means blood is going away from the probe. So can I say using this Doppler effect or attributing colors to frequency shift enables me to know the direction of blood flow? Yeah, so color Doppler tells us the direction of flow. Red means towards the probe, blue means away from the probe. Please don't do silly mistake here and say red matlab artery, blue matlab vein. Leave that in first year. Now you are not doing that. Now you are doing radio. Okay, so this is red towards probe, blue away from probe. All right. So what is the utility of this? Look at this. This was also a PYQ. What is this? This is a Mickey Mouse sign. But that's not important. What is important is what is the significance of this saphenofemoral junction. This is what we use in varicose veins, right? Saphenofemoral junction incompetence is one of the major causes. So what do I do? Normally, the blood has to go from the great saphenous vein to common femoral vein, and that's what this valve is for. If this valve is incompetent, do you agree? The blood now goes opposite. The blood is going to go from common femoral vein to SFJ or great saphenous vein, and that results in varicosity. So do you agree if I keep a probe here, I can see agar color, because we don't see arrows, right? We see color. If I see that the blood is blue, right? I see a blue color. What does that mean? It means that the blood is going away from the probe, isn't it? And is that normal? Yes, that's normal because that represents this direction. But if I see that the color is red, what does that mean? That means that the blood is flowing towards the probe. And is that normal? No, that means there is incompetence. So using the color, I can know whether there is incompetence or not, and that is why for varicose veins, my investigation of choice is Doppler ultrasound. Understood? So this is color Doppler, also called as duplex, right? So this is color Doppler or duplex ultrasound. Then look at this. There is a B mode ultrasound. There is a color Doppler, and I can also see a spectrum. So this is what is called as spectral Doppler, where now I'm seeing three things. So this is triplex ultrasound, and this tells me the velocity of flow. So this spectrum is telling me velocity, systole mein upar, fir diastole. So this shows me the waveform, right? So using the spectrum now, there are either this one, which is called as triphasic waveform. You can see systole mein upar, then diastole mein it's going down, and then there's one more. So this is called as triphasic waveform, and this is what is called as monophasic waveform, single. So triphasic waveform is what is seen in normal extremity arteries. So this is what we pick up in normal extremities. Means if I'm doing a peripheral arterial Doppler in a patient who has intermittent claudication and I see triphasic, it's normal, right? So this is the first investigation that I do for arteries. Doppler ultrasound, I see the waveform. If this becomes biphasic, means this is lost, or becomes monophasic, means it's abnormal. So this is abnormal for arteries. But can I say this is the normal waveform for veins? Because veins don't have systole, diastole. They have one job, to bring the blood back to heart. So for veins, this is normal waveform, right? So remember that. So can I now detect deep vein thrombosis? Yes, I can. So what do I do here? There are two ways to detect deep vein thrombosis. The investigation of choice again is Doppler. First, I can do using B mode only. Look at this. Let's say this is femoral artery and this is femoral vein. If I compress using my probe, can I say femoral artery will remain as it is, but the vein would get compressed? So if there is compressibility, it's a normal vein. But if the compressibility is lost, non-compressible, that's deep vein thrombus, because there is a thrombus within. So this becomes non-compressible. If I see that the flow is present, what is this flow? This is called monophasic flow. So monophasic flow matlab normal. But if there is a thrombus, I will see no flow. So that's absent flow. So this is what we have to understand here. Two more images from ultrasound which show you, two advances. I feel this may be asked, never been asked. So look at this. The moment you see red and blue, please don't say Doppler. That's the mistake most of your friends will do, but not us. So what is this? This is where there is a nodule in thyroid. This is a thyroid ultrasound. And just for context, see, this is trachea. Can you visualize thyroid? First of all, this is the isthmus, butterfly shaped. So this is trachea. Can you see behind trachea? Nothing is seen. Dirty shadowing. Are you understanding? So this is trachea. Within trachea was a nodule. And I'm measuring the stiffness. Red means high stiffness. Blue means soft. So this is what is called as ultrasound elastography. I am measuring the stiffness of tissue indirectly, right? So this is what tells me stiffness, and what it represents is anything which is hard is more likely to be malignant, right? So this is what I use as another perspective to differentiate benign and malignant masses कि अगर उसका elasticity hard है, that means it is malignant. So this technique they will ask, this is ultrasound elastography or shear wave elastography. You can also call it shear wave elastography. What is this? This is what is CEUS, contrast enhanced ultrasound. Just like how we were giving iodinated contrast in CT, I can use contrast which is injected in ultrasound and then do an ultrasound. We will talk about that in a minute, but this is what it looks like when you give contrast. So whenever you see this orangish, goldenish hue, it is contrast enhanced ultrasound, right? So that's done. Now let's talk about the thumb rules for ultrasound, something we've already done. So anything in the gallbladder, investigation of choice is ultrasound. Gallstones, cholecystitis, everything. We will see all of these in surgery. Any fluid, any cyst, we have already established ultrasound. So the best investigation, the most sensitive investigation for effusion, pericardial effusion, ascites, any fluid, ultrasound. In pregnancy, the first line investigation that I do is ultrasound because it's readily available, no radiation. So can I say in pregnancy, I have only two options. Either I can do ultrasound or I can do MRI because they do not have radiation. So ultrasound is first line, MRI is only used as problem solving tool. So mainly two indications for MRI in pregnancy. One is a fetal MRI. You are suspecting some gross fetal anomalies and you want to visualize the entire body very well. The second is placenta accreta, where the placenta is invading into the adjacent organ. So this entire spectrum I can do. So those are the two main indications. Otherwise, ultrasound suffices for most of the things. Investigation of choice for venous pathology is Doppler. The ball stops here. Just Doppler, DVT, varicose. But for arterial diseases, the first thing that I will do is Doppler. Let's say somebody has peripheral arterial disease. I first do Doppler and look for triphasic waveform. Let's say it's lost. The best investigation is a CT angiography. What is CT angiography? It's like a CECT. I am injecting contrast and visualizing, right? So that is CT angiography. But when they ask what is gold standard? Gold standard matlab something which is not just diagnostic, it can offer treatment also. So that's just one thing. Gold standard essentially means which has highest accuracy, called best, right? So that's gold standard. Do you agree something which can treat also has to be the best one? So diagnostic and therapeutic is DSA. So what does DSA stand for? Digital subtraction angiography. So this is what is our field of interventional radiology. What we do in IR is we puncture the femoral artery, is the most common access. So I puncture the femoral artery because it's easy to get compressed under the femur, right? So that's why we prefer femoral. I take my wires and catheters and go into any vessel which needs treatment. Let's say peripheral arterial disease. We go into the artery and we put a balloon catheter. We inflate a balloon such that that vessel opens up. The atherosclerosis is removed. So that's what is balloon angioplasty. Similarly, if there is an aneurysm, we can put in a coil, right? So this method is digital subtraction angiography, which is invasive. You are going inside the vessels, right? So this is the flow for arterial diseases. So this is our concept for ultrasound. The last part of general radiology. Now, this is super important. Everything. I've spent so much time on general radio and concepts that after this point, all we have to see is see multiple pathologies, images, and learn the pattern, right? But this is your fundamental radio that I want you to understand. Contrast media. Now we said we have 4 different contrast media, right? So iodinated contrast media is the one that I use for X-ray or CT. If I want to, do something like an IVP, we will study that next. Intravenous pyelography. I can inject iodinated contrast and see it with an X-ray. So I use it for X-ray or CT. Injection can be given IV or through any route. For example, if I want to do ERCP, I can put contrast in the CBD as well. So any route we can put iodinated contrast because it's water soluble, it is safe. Okay. The only prerequisite is it will get excreted from the kidney. So your renal function test has to be normal. So the eGFR less than 30 is a contraindication to using iodinated contrast because it can lead to acute tubular necrosis. So somebody who already has deranged renal function, we can't use contrast. So the complication is contrast induced nephropathy. So any AKI that develops within 48 hours of contrast injection, this is what is the definition of CIN, which is contrast induced nephropathy. The definition of AKI that CIN uses is any increase in creatinine, either 0.3 by mg per dl absolute increase or any increase more than 50% from baseline. So either it can be relative 50% from baseline or it's 0.3 mg per dl increase. Means if the pre-scan creat, let's say, was 1 and now after giving contrast within 48 hours it goes to 1.4. So that's CIN, right? How to avoid CIN? There is only one proven method. So in any patient who has deranged renal function, there's only one thing to avoid CIN, which is hydration. Give IV fluid. So anybody who is at high risk, the only thing that may prevent CIN is what is hydration. Right? So that's very, very important. Then gadolinium. Gadolinium is MRI contrast agent. If I want to do MRI and give contrast, the brain tumor that I showed you, we use gadolinium. IV only. Only IV. Again, RFT is a prerequisite. Same eGFR is the contraindication here as well. And if you give it in deranged renal function, this accumulates. This gadolinium accumulates in different tissues and that is called as nephrogenic systemic fibrosis. So this is nephrogenic systemic fibrosis where the gadolinium accumulates everywhere. Then you have SonoView. So SonoView is ultrasound contrast agent. I showed you CEUS. So this is also given IV. The best advantage is this is safe in renal failure. This is the only IV agent I can use if patient has deranged renal function. The only prerequisite, what is SonoView? It's actually sulfur hexafluoride gas, right? So that is why you must rule out sulfur allergy, right? So if one has sulfur allergy, we may not be able to use it. Because this is sulfur hexafluoride gas bubbles, small bubbles, micro bubbles, it's excreted through the lungs and that's why it's safe in renal failure. Lastly, coming to barium. Now, barium sulfate is what is used with X-rays and the only route in which I can give barium is either orally or as an enema, meaning it has to stay within the gut. It cannot go outside the gut. Means if there is somebody who has, let's say, a perforation or they have obstruction, intestinal obstruction, I will not use barium because it will leak out and further add to peritonitis. So what are the contraindications of using barium? Perforation, obstruction, can I say tracheoesophageal fistula? Can I also say post-op patients where the anastomotic site, post-op bowel anastomosis, I will not use because through the anastomotic site the barium can leak out. So in all of these I will not use barium, but can I use iodinated contrast? Yes. So iodinated contrast being water soluble is preferred here where barium is contraindicated. So you will use iodinated contrast whose names will be something on the lines of IO. So iohexol, or the trade name is gastrografin. So you will prefer iohexol over gastrografin because it's a newer iodinated contrast agent, but either of them can be used. So this is about the contrast media, and I'll tell you further about how we name the barium studies as we go into the systemic part of radiology. Now, when we start our approach to systemic radio, a lot of it I'll cover in the respective subjects, right, where the clinical part is relevant. So we'll do it there. But wherever there are some standalone concepts which I have to tell you, I'll do it here. So essentially radio is, even though this video is like pretty long, but it will be covered in multiple different subjects. It's a part of every single branch of medicine, right? So that's how we will study radio, but this is your fundamental starting block. That's how you have to treat it. So with this, we close general radio and then we'll begin systemic radio. So now let's start discussing GI and hepatobiliary. A lot of overlap with surgery. So we'll mix it up and do. So let's start off with the nomenclature of barium procedures. We said barium is something that you either ask the patient to, drink, or you give it as an enema. So when you ask the patient to drink, there are three things that we can do. If I am visualizing the esophagus, right, the patient drinks the barium and it goes down the esophagus. This is what we call as barium swallow, right? So barium swallow is for esophagus. Then the patient drinks the barium, further after some time it goes into the stomach. So when I visualize the stomach and this part, which is D1, proximal duodenum, this is what we refer to as a barium meal, right? So barium meal helps us see stomach pathologies and proximal duodenum pathologies. Then you further wait, all right, you ask patient to drink more barium. Now you see that it's opacified the small intestine. So when my focus is the small bowel, that is what is called as barium meal follow through. So I'm following through. So that is what we call as BMFT, barium meal follow through, and this is for visualizing small bowel. Now, small bowel is duodenum, jejunum, ileum, right? So duodenum we can easily make out as this structure. So you can see D2, you can see D3, and this is the D4 where it crosses over on the left side. That is also something important that we note, because if the duodenum D4 does not cross onto the left side, it's one of the signs of malrotation. Okay, so one point to be noted is this should cross onto the left side. So that's one. Then jejunum and ileum. So can you see how these loops are all very feathery? They have a feathery outline. So this feathery outline is what is seen in jejunal loops, whereas these are the ileum loops where you do not see any feathers, you do not see any folds, right? So the reason for that is jejunal loop has these complete mucosal folds which are called as valvulae conniventes. It's also called as valves of Kerr-Ring. You can remember either one. So valvulae conniventes or valves of Kerr-Ring. So that is jejunum. Ileum, no folds. Imagine somebody's feature it's featureless. It's so insulting if somebody says that uska best feature hai, there's no feature. So ileum is recognized by the fact that it's featureless, right? So this is barium meal follow through. Now look at this. If I ask you what bowel loop is this? So you'll be like, ma'am, wow, I'm seeing the complete mucosal folds. What are these? These are valvulae conniventes, right? So this is what is jejunum. And you can see the difference between this and BMFT is that there's a tube now. And the distension is much better, because of which you can see these mucosal folds very well. So what is this? This is what is barium enteroclysis. Right, so this is barium enteroclysis, where instead of asking the patient to drink the barium, I put in a tube, right? We put in a tube till the DJ flexure and you inject the barium. So that gives you much more control over how much barium you're injecting and the distension. So the advantage is that the distension is much better. So I can say that both barium meal follow through and barium enteroclysis are going to help us visualize the small intestine. The distension is better in barium enteroclysis. Then look at this one. This is where we are injecting the barium through enema. If I want to see large bowel, there's no point asking patient to drink barium and wait till large intestine, right? So we rather inject it as an enema from the rectum, and this is barium enema. And what do you see in the large bowel? Can you see how there are these incomplete folds in the colon, which are called as hostrations, right? So we see hostrations in the large intestine. So that is how we name these different barium procedures. All right. Then let's talk about esophageal pathology. So now we are going to see some barium of esophagus and we'll recognize. So these are just spotters that you have to see. Look at the first one. You can see how esophagus is dilated and you see this tapering at the distal end. The most important, the most frequently asked question is this one. So when you see that there is this smooth tapering distally, see, smooth tapering is what I am focusing on. I am not focusing on bird beak, rat tail, no. Focus is it's very, very smooth, and that is why it's a benign condition, that is achalasia cardia. What happens in achalasia is this lower esophageal sphincter does not relax. It is very, very tight. So because it does not relax, there is no peristalsis that can go forward. So the pathophysiology here is that there are inhibitory neurotransmitters which are VIP and NO in the lower esophageal sphincter which are absent, because of which the esophagus does not relax. The lower esophageal sphincter does not relax, resulting in this smooth stricture. So it's not a true stricture because it's a motility disorder. Can I say it's a motility disorder? I can confirm this diagnosis on measuring the pressure. So that is called as manometry. I do manometry to measure the lower esophageal sphincter pressure. So that's one. Then what kind of dysphagia will you have? Because this is not a mechanical obstruction, it's a functional obstruction. What happens? When I eat solid food, they can exert pressure and open the valve. But when I drink water, that's not enough to distend the lower esophageal sphincter. So the dysphagia here is more for liquids than solids, more or equal to like solids, but it's more in liquids. So that is what is achalasia cardia. Now, the traditional sign that this is described as is called as bird beak sign because it is very smooth. But Bailey Love writes this as rat tail. So when you have both options, you write bird beak. But when you don't have both options and you are made to choose rat tail, you're like, okay, fine, let's keep it light, we'll choose. Right? So that's why I'm giving you both versions. The term rat tail sign was traditionally described for this irregular narrowing. What is this irregular stricture? Now this is cancer. So this is CA esophagus, right? And this is what has been described as rat tail sign. And you have this irregularity, you have shouldering which is produced, okay? And the investigation of choice for this is going to be upper GI endoscopy, and we do a biopsy to confirm. How will the dysphagia be? Very obvious, right? Because cancer is a fixed obstruction. Your water can pass through it, but not solid. Solid foods will get stuck. So that is why here the dysphagia is more for solid than liquid. And what is this investigation? This was asked in FMG last year. This is endoscopic ultrasound. Can you see how there is this? This is the probe and this is the esophagus. So you can see that there is a mass here, and look at this black and white lines. These represent the different structures of the bowel. So this is mucosa, submucosa, muscle, serosa, so you can see exactly how much the tumor is invading. And that is why this EUS is the investigation of choice for T and N staging of C esophagus. For M staging, we know everywhere I'm going to use PET-CT, right? So this is the investigation of choice for T and N staging of C esophagus. So these are the two most important. The others just need to know what they are representing. So you can see there are these lines. So this is what is called as a feline esophagus, and this represents eosinophilic esophagitis, right? So if you do a biopsy, you will see eosinophilic esophagitis, and as the name suggests, this is associated with atopy. The patient may have asthma as well. If I say this is a patient who has HIV/AIDS, any patient with HIV/AIDS presents to you with odynophagia. The most common diagnosis is candida. So this is esophageal candidiasis, and this is an AIDS defining illness. So remember, esophageal candidiasis is AIDS defining, but not oral candidiasis, right? So this is what is an AIDS defining illness, all right? And this appearance where you see so many such erosions, this is what is shaggy esophagus, right? So this is what has been described as a shaggy esophagus candidiasis. All right, so that is why any patient with HIV AIDS who has odynophagia, you know what's the next step? You don't do barium, you don't do biopsy, you straight up give fluconazole. You start the patient on empirical fluconazole. If the patient does not improve on empirical fluconazole, then you do a barium or you do an upper GI endoscopy, which is better, and then you see for two other causes. So here, if they give you that the patient has these volcano-like ulcers, which are deep, punched out ulcers, what is that? That is HSV esophagitis. But if they say there are big shallow ulcers described as serpiginous ulcers. So serpiginous shallow, so for CMV, right? So that's CMV. So for HSV, you treat with acyclovir. For CMV, you treat with ganciclovir, right? So that's how odynophagia plus HIV is treated or approached. So you give fluconazole. If it doesn't respond, then do endoscopy and decide. All right, so this is shaggy esophagus candidiasis. What is this? This is where the esophagus looks like a cork screw. So this is what is called as a corkscrew esophagus or diffuse esophageal spasm. This is also a motility disorder. We can do manometry. Then more barium swallows. What is this? So this is a diverticulum. You can see it's a posterior diverticulum. What is this? This is a Zenker's diverticulum. It comes out at the Killian's dehiscence. What is this dehiscence or weak area? It is the area between thyropharyngeus and cricopharyngeus. So these are the two parts of the inferior constrictor. So there's a gap in between through which this diverticulum comes out. That's called Killian's dehiscence. This is a false diverticulum, means it does not have all layers. The only true diverticulum is Meckel's. Also, it's a pulsion diverticulum, means it's pushed out, right? So this is Zenker's, and the treatment, let's finish it right here, right now, is Dollmann's procedure. So Dollmann's procedure involves stapling. Nowadays we do endoscopic stapling. So you close this, because how does this present? This is where the food, gets collected. So the patient will give you history of regurgitation, halitosis, right? So that's the history. So you close this diverticulum. So this is Zenker's. This was asked to label. So this is what is the normal barium appearance, and you can see two parts here. So these are parts of the larynx. So the part above that we've learnt in ENT as well is vallecula, anterior recess, and the posterior deeper recess is piriform sinus. So you can see this getting outlined by barium. So this is vallecula, this is piriform sinus, this is normal anatomy. Then compare and contrast these two defects. One is linear unilateral defect in the proximal part. So this is only on one side. Second, it is in the proximal esophagus near the cricopharynx. This one is in the distal esophagus, right, just above the stomach. And second, it is bilaterally there, means this is actually what is a ring. So both of these are mucosal defects which you can see. So when it is a single linear defect, it's a esophageal web. But when you see it as a ring circumferentially narrowing, this is what is an esophageal ring. Let's discuss further. So for esophageal web, you want to remember what syndrome? Yes, Plummer-Vinson syndrome. So Plummer-Vinson syndrome is where you have web, you have iron deficiency anemia, and you have glossitis. The importance of this is pre-malignant, right? So this is what can predispose to squamous cell carcinoma of the hypopharynx. So this is Plummer-Vinson. Then you have esophageal ring. So this is what is called as Schatzki ring, and these rings are of two types. The more commoner one is B. So unless mentioned otherwise, you will say B. So B is the ring which is more proximal. All right, so this is the one that you are seeing here, and this is associated with hiatal hernia. So frequently there'll be a hiatal hernia. What is a hiatal hernia? The G junction gets pulled up into the thorax, and just proximal to that you have this ring. All right, so it is the Shatsky B ring which is present at the squamocolumnar junction, right? And then you have the A ring. So it's Shatsky B ring which is going to be more distal. So think of it like this. Right, so this is the stomach. So this is stomach, this is esophagus. So this distal one is B and the proximal one is A. So B is the more constant one. It is A which is just a transient constriction, right? So Shatsky B ring, more distal, closer to the stomach, and it's more common. So this is about few bariums. Few more barium swallows now in the distal part of the bowel. So look at this barium meal follow through. Can you see this is jejunum, this is ileum, and this is the terminal ileum opening up into the cecum. So whenever you have this terminal ileum narrowing, this is what we call as string sign. Now, terminal ileum can be involved in two things. Typically, if only terminal ileum is involved, this is Crohn's. All right, and this is where we call string sign of Cantor, right? So this is a terminal ileum stricture. It's the most common site involved in Crohn's disease. So this is string sign of Cantor. But if you have ileum narrowing in association, you have ileocecal junction involvement, and you have words like contracted cecum. Yes, this is what is TB. So for TB, ileocecal junction is what is most commonly involved, and there can be associated ileum involvement, but it's IC junction which is essentially pulled up cecum, contracted cecum. Those are the words they will use. So this is what is the string sign. Then look at these two images. What are we seeing? Where are the hostrae? The hostrations of the colon are lost. Can you see this colon without any hostrae? So this was asked in last year INICT question in 2024. So what is this? This is what is lead pipe colon. It looks like a pipe. The hostrations are lost. So this is what we see in UC. UC versus CD, we have learnt it in GI. So ulcerative colitis is continuous involvement of colon being more common, whereas Crohn's is skip lesions most commonly affecting the terminal ileum, right? And then look at this, it looks like it's an eaten up apple. What is this? This is apple core sign which represents CA colon, right? Then something very, very important, pneumoperitoneum. Look at this chest x-ray. Whenever you look at this chest x-ray, this patient has intense pain abdomen. You look below the diaphragm. Left diaphragm, black air, normal, because this is the normal stomach gas, fundus gas, not abnormal. But when you see gas on the right side, air under the right diaphragm, that's always bad news, because here you had liver. What is air doing here? So you know, when I'm in a sitting position or a standing position, air will go against gravity. So if there is a bowel wall perforation and air is there in the peritoneum, it will come up against the diaphragm. So that is why the best investigation, or better put, the next best investigation that we do in a suspected perforation is always chest x-ray PA erect view, where the patient is standing and you see air under the right diaphragm. Don't look below the left diaphragm. Yes, so this is right air under diaphragm is what we are seeing in this chest x-ray. So let's go through the patient first. This is where there will be a history of a patient who has sudden acute severe pain abdomen. Not just that, there will be signs of peritonitis. So there will be guarding, there'll be rigidity, there'll be tenderness, right? So the patient will be in intense pain with physical findings, and they will ask you, what are you suspecting? So we are suspecting a perforation or a pneumoperitoneum. So what do you do next? So they will say, what investigations do you want to do next? So you will say, I want to do a chest x-ray PA erect view, and that will show me right air under the diaphragm. So you are like, okay, take this, it is showing. What next? So now this is a surgical emergency. Don't investigate him further. You got your answer. Now you will go on with surgical exploration. But If IV fluids is in the option, give IV fluids. Even if patient is stable, you give IV fluids, his vitals may be stable. But do you understand? He has a perforation. He is leaking out contents from his bowel. Obviously, he is dehydrated. So give him IV fluids. Next step, IV fluids. If they ask you what is the best management or the most definitive management, it is going to be exploratory laparotomy. It is going to be surgical exploration. Have you understood this? So, chest X-ray PA, you found air under diaphragm, IV fluids followed by surgical exploration. But if they ask you what is theoretically the most sensitive investigation to detect air? Ultrasound? No. Enemy. What is the best? CT. So anything where X-ray is done, the best is going to be CT. So let's say there is some air only, not seen on X-ray, but my clinical suspicion is high. Then what can I do? Then I can do a CT. So the investigation of choice is CCT. Not just that, can I make the patient drink some oral iodinated contrast? Yes. What benefit will that do? That will help me see the site of leak also. Wherever white contrast is coming out is the site also. So that's the additional benefit. So CT is the best, but will you always do it? No. No need to do it if X-ray shows you the findings. So it may be done, it should not be done, is what is the best way to remember. Will you ever give barium to this patient? Not at all. We know barium, big no in perforation. So look at this CT scan. On a CT, the air will come aage, isn't it? Because the patient is supine, it will come anteriorly. So can you see this kala black air, negative 1000 HU, very black. So this is what is pneumoperitoneum. Now I want you to see this. Here also I can see air under the right diaphragm, but is this air really pneumoperitoneum? No. Look carefully. This is actually hostrations which are seen. So this is what is called as Chilaiditi syndrome. What is Chilaiditi syndrome? It is pseudo pneumoperitoneum. So this is where you see hostrations. It's actually an anatomical variation where the colon comes between diaphragm and liver. So this is not pneumoperitoneum, it's a normal variant, right? So this is done. In kids, if they have severe pneumoperitoneum, you may see a sign called as football sign, right? Can you see how there is air all around? So this is called football sign, and this is usually seen in context of necrotizing enterocolitis. Stage 3B is pneumoperitoneum. So this is there. Then there are multiple named signs on the X-rays which have been described. Sometimes you might just see this black air in the center here. That is called cupola sign. Sometimes you may see air outlining the falciform ligament. That is called falciform sign, right? So these are a few names which have been described. Then there's something called as Wriggler's sign as well. So multiple signs have been described. You just need to know their names. What Wriggler sign essentially means is you see inside and outside the bowel wall, there is air on both sides. There's black air inside obviously, but outside also there's air. So that's called Wriggler's sign. Okay, so this is what we need to remember here. This is different from Wriggler's triad, remember. That's something we'll do in surgery. That's gallstone ileus. So that's Wriggler's sign, that's Wriggler's triad. Alright, so this is about perforation, super important. Then we deal with intestinal obstruction. So, bowel already has air. So when do I call it obstructed on the X-ray? So for that we have first of all a rule of 3, 6, 9. When is bowel abnormally dilated? So if small bowel diameter is more than 3 centimeter, large bowel more than 6 centimeter, cecum more than 9 centimeter is called to be abnormal. So that's the first finding. Now, history-wise, patient will complain of pain, there will be obstruction, no passage of stools or flatus, which is called obstipation, and there will be vomiting, right? So here, what you have to do next, first of all, clinically what you will do next is 1, start patient on IV fluids. Second, keep the patient nil per oral because obstruction is happening, and you put in an NG tube because you want to decompress the bowel. So you've done all of these preliminary things, and now you go in with the next step, which is going to be an abdominal X-ray. So you said, ma'am, give me X-ray. I'll diagnose obstruction. So I gave you X-ray. What is this? So this is where you'll say, ma'am, okay, I'm seeing these valvulae conjunctivis and I'm seeing multiple air fluid levels, almost like a step ladder pattern. What is this? This is small bowel obstruction. So small bowel obstruction, I'm going to be seeing some central loops. The diameter would be more than 3 centimeters. I would see valvulae conjunctivis, which tells me that this jejunum which is dilated. Most of the ileal loops are here, so there is no ileal dilatation. So I'll say, to be precise, this is proximal small bowel obstruction, where there's jejunal obstruction essentially. Isn't it? Step ladder pattern is seen. No hostrations. On the other hand, if I see an X-ray like this, can you see this loop is having air? And you can also see the cutoff point, that it is going on till here, means there must be a cause here. And can you visualize the presence of these incomplete folds, which are hostrations? So these are peripherally distributed bowel loops. Diameter is more than 6 centimeters. No valvulae, no step ladder, but yes, I can see hostrations. So this is how, on the basis of the X-rays, you will diagnose whether it's small bowel or large bowel obstruction. The most common cause of small bowel obstruction are adhesions, which are formed because of prior surgery. So this is far more common. Small bowel much more common than large bowel, whose most common cause is actually cancer, and the most common cancer in the large bowel is at rectum. The management of small bowel obstruction is conservative. You continue with, these things that you have done already. If the patient worsens, then we operate, otherwise we wait. The reason for that is it was happening because of adhesions. Now, if you keep opening up the patient, it's a vicious cycle. They'll develop more adhesions, more obstruction, never ending. So that's why you break the cycle, you stop doing surgery. But if it is cancer, you can't say, you please wait, and if your cancer doesn't disappear, I will operate. No, so it's not disappearing. So that's why here next step is surgery, particularly in CA rectum. If the patient presents in obstruction, we do something called as Hartmann's procedure, right, where you directly take out a colostomy for the fecal matter to drain out. All right, so this is about obstruction. Now, so far I was discussing mechanical obstruction, where there is a cause of obstruction. What is paralytic ileus? Paralytic ileus is non-mechanical. This is where the bowel sounds they will describe are decreased. In mechanical obstruction, they are increased. There is hyperperistalsis. Here, it's decreased because this is happening usually in context of post-op or electrolyte imbalance. So because of electrolyte imbalance or post-op because of the anesthesia or the opioids, the peristalsis decreases. So the bowel looks obstructed because it's just not moving. But there is no transition zone. What do we mean by transition zone? It means a point before which it was dilated. For example, this is the transition zone. In paralytic ileus, every bowel is dilated. No transition zone. So 3 buzzwords: bowel sounds decreased, no transition zone, and you will have history of either post-op or electrolyte imbalance, and the management is treat the underlying cause. Only when the underlying cause is, not being treated or it's refractory, only then can we give cholinergic drugs like neostigmine, which will increase the peristalsis. Right, so this is the management of intestinal obstruction. I'm integrating everything here from surgery. Means I'll not repeat this again in surgery. Whatever I'm covering here is done here. Whatever I'm not covering here will be completely dealt with in surgery. So we avoid repetition, right? Because our time is very valuable. So this is intestinal obstruction. Then on the same lines, let's talk about volvulus. What do I mean by volvulus? So volvulus is when an organ is getting twisted upon its own axis and getting obstructed. So this could either be sigmoid or cecal. So I'm showing you 2 images. What do you think? Both of these are having what? Can you see there are 2 bowel loops which are dilated? Can you see there are no hostrations in these tubes? Yeah, so this is what we call as our coffee bean sign. Some people also call it as bent tube sign. So coffee bean is better because coffee is better. So this is what is sigmoid volvulus, right? So sigmoid volvulus happens with a background of chronic constipation. So this is where they'll give you a history of chronic constipation, and the bowel sigmoid colon twists on its own axis. Two buzzwords that you will look out for. One, there are no hostrae, it's ahostral. And second, usually you will see two bowel loops which are dilated. Because this is happening due to chronic constipation, the management is simple. Put in a flatus tube or an endoscope, and that will allow for the bowel to detort itself, right? So that's what you are going to be doing. So this is what is sigmoid volvulus. On the other hand, look at this one. Now there are no two loops. There's a single bowel which is dilated, whose diameter has to be more than 9 centimeter. Remember, 3, 6, 9. And you see it's a single loop, and can you all make out hostration here also? Here also. So what is this? So this is where I have ruled out sigmoid. Single loop hai and hostrae hai. So that is why this is cecal volvulus. Okay, so cecal volvulus, this sign has been called a C sign, a single loop like a C. But what is more important is there is the presence of hostrations and it's a single loop. This is associated with either pregnancy or some sort of pelvic surgery. So you can remember CP, pregnancy or pelvic surgery, and the treatment is going to be surgical, right? This will not solve itself. So this is cecal volvulus, right? So that finishes off obstruction for us. With this, we wrap up GI radio. Next is genitourinary, where we talk about mainly urorad. Alright, so we start off with IVP. So the first investigation, that is IVP. What does this mean? So this is intravenous pylography. This is also referred to as IVU. So that is IV, intravenous urography. So what this tells us is that I'm looking at the collecting system of the kidney. So what I do here is I give IV contrast. So we inject IV contrast. We wait for around 10 minutes. You know the contrast, iodinated contrast is going to get injected through the kidney. So that's what we do. We wait for 10 minutes. When the contrast comes into the calyces, pelvis, ureter, bladder. So I can see that. So all you do is inject contrast, 10 minutes later take an X-ray, right? So that's IVP. Look at this one. This is where you can see the distal end of ureter is very increased in size. It's bulbous, and this is what is ureterocele. It is the cystic dilatation of the distal end of ureter, and this is what has been described as an adder head or a cobra head, just like cobra's head, which is bigger than the body. So this is ureterocele. Then look at this one, these two images. So this is where now, what is different from this IVP? You can see instead of the normal, lateral orientation of the kidney, you can see how they are trying to talk to one another. Why? Because the inferior pole is fused. So this is where you can see that the lower pole looks as if they are trying to shake hands. So this is what has been described as shaking hand calyces or a flower vase sign. So this is shaking hand calyces or a flower vase sign is what you are seeing here. And why is this happening? It's happening because this is a kidney that has fused inferiorly. And what do we call that? We call this horseshoe kidney. So this is horseshoe kidney which is fused at the inferior pole. So now what is this part here? So look at this. Normally kidneys form in the pelvis and they ascend up and lie at L1, L2, L3. This is a kidney which is fused at the midline and it's trying to come up. So what happens? As soon as it's trying to come up, it meets the aorta and its ventral branches in the midline, and the lowermost branch is IMA. So we see that always anterior to the isthmus is going to be the inferior mesenteric artery, which stops the ascent of kidney. So that is why this horseshoe kidney is more inferiorly located than normal kidney. That's one point. The second point, that horseshoe kidney undergoes as a problem is the ureters are going to go like this, right? So there is a lot of stasis which can happen. So because there is more stasis, there is higher chance of obstruction of urine, higher chance of calculus formation, right? So that is what you need to remember in horseshoe kidney. The syndrome associated with horseshoe kidney, I'm sure all of you know, is Turner syndrome. So look at the CT. First of all, what is this? CECT. Bone is white, aorta is white. So this is CECT, and you can see the kidney fused in the midline. This is isthmus, and what must be this tiny little baby vessel? It has to be IMA, isn't it? Because that is what will always be a constant relationship between the isthmus and the inferior mesenteric artery. So this is horseshoe kidney. Then look at this. This is where you can see that the right kidney looks as if it's drooping. So this is what we call as the drooping lily sign. So this drooping lily sign is where you can see that this pole is drooping. Now what it really represents actually is a duplicated collecting system. So here the right sided kidney is actually duplicated. So this is duplicated collecting system, and now what happens to it? Let's learn that first through this rule. What is this rule called? This is called Wiegert-Mayer law. This is where vowels stick together. You remember our vowels A, E, I, O, U, they stick together. Means what? This is the upper moiety of the duplicated collecting system. This is lower. Means upper and lower are being drained by two ureters. So what happens to the upper ureter? Upper ureter is more predisposed to developing obstruction because it's a vowel. It is more predisposed to being ectopic in its opening, and you can see how it opens inferomedial to the trigone. So if it is opening in the bladder, it will open inferomedial to the trigone. So either it can be ectopic like here you can see, or it is inferomedial, or it may undergo obstruction. So because of the obstruction, what may happen is this part is not seen only. So you can see upper moiety gayab, it's not seen, and that's why the kidney looks as if it's drooping, because I only see the lowermost pole here. So that is what we see, and this is the lower pole, that's why it looks drooped out. So this is the one which undergoes a complication of VUR, not a vowel. So lower moiety predisposed with VUR, upper moiety obstruction, ectopic, inferomedial. So that's drooping lily, duplicated collecting system. Now what we are seeing is an approach to white kidney. Look at 1, 2, 3, 4. Everywhere you can see that, ma'am, kidney white. Let's delve further. The first one, this is where you can see how the complete kidney on an X-ray is white. It looks like it's completely filled with cement. So this is what is putti kidney. So putti kidney, completely calcified kidney, and this is what represents the end stage of genitourinary TB. So let's understand renal TB. First of all, how did it come to the kidney? It came via hematogenous route. So kidney is the most common site of genitourinary TB, comes via hematogenous route. As soon as the TB bacilli enter the kidney, they're first going to go through the calyx, then pelvis, then ureter, and then bladder. TB has a tendency to cause fibrosis wherever it goes, right? So first it will cause the narrowing of the calyx, and that is why the earliest sign is moth-eaten calyx. The calyx looks irregular, and that's a finding that we see on IVP. Then it will narrow down the complete ureter. It will look like either a pipe stem ureter or a golf hole ureter. So pipe stem or golf hole ureter is what we see there. And finally, it reaches the bladder, and that is what is called as a thimble bladder. So that's called thimble bladder. So pipe stem or golf hole, and then thimble bladder. Alright, so that is what we see in GUTB, and that is why it presents as increased frequency. So the most common clinical feature is increased frequency of urine, and this is your NEET 24 question, golf hole ureter. How to diagnose? So they will describe a word called as sterile pyuria. So there are pus cells in the urine but no bacteria. because it's TB bacillus, it's not E. coli. So that is why what can we do? We can do a urine acid fast bacilli testing, and that can detect TB. So that's the treatment. And finally, when everything is done and dusted, the last stage where the kidney becomes non-functional is putti kidney, and this is what we label as autonephrectomy. So this is as good as not having a kidney. So one hint is this will always be unilateral. You can't be walking around with two non-functional kidneys, right? So there will always be one kidney completely white. So this is your entire renal TB spectrum. Then we see this. You remember how for stones investigation of choice was NCCT? What is this stone? Such a big stone occupying complete collecting system. This is what we call as staghorn calculus, right? So this is frequently made up of struvite. Yeah, so this is staghorn calculus made up of struvite, big stone, occupies collecting system. Then look at this, white kidneys but both sides. And second point, when we look more carefully, it is just the medullary pyramids which are white. So this is what we call as medullary nephrocalcinosis. So this is medullary nephrocalcinosis, where we can see this calcium in the pyramids. This happens because of hypercalcemia. So when you have systemic hypercalcemia like hyperparathyroidism, this is a PYQ, we can see medullary nephrocalcinosis. It can also be associated with a condition called as medullary sponge kidney. So it can also be seen with medullary sponge kidney, where there is again calcification in the medullary pyramids. So that's nephrocalcinosis. This can be bilateral because here the kidney function is not really lost like putti kidney. Okay, and lastly, look at this. This is where they have given an IVP especially. All of the others were X-rays so far. X-ray pe white matlab calcium. But this is IVP, so it's not calcium. What do we see here? You can see how the kidney is dilated. There is hydronephrosis, but the unique thing is that the pelvis is dilated out of proportion to the calyx. And you can see there is no contrast going into the ureter. Means what is the level of the obstruction? It is here. So this is what is pelviureteric junction obstruction. So there's an obstruction at this level here, not allowing the kidney to excrete the urine, resulting in a flank lump. They will tell you there's a mass felt. Every time patient drinks a lot of water, there is a mass which is felt, and that is called as Dietl's crisis, that there'll be a sudden mass that happens on drinking a lot of water, and suddenly it'll allow the urine to pass through and it will open up, it will disappear. So it's a mass which comes and goes, very unique history, right? So that's PUGO. This CT was asked. First of all, CT makes sense, bone is white. Then what can you see? That this is the CSF. So this is just like CSF, means ye bhi fluid hai. So right and left, only right kidney is affected. So this, the various DDs here that go through your mind is this autosomal dominant polycystic kidney disease? No, that has to be bilateral. Is this a simple renal cyst? No, it's not a simple renal cyst. Where is the rest of the kidney, and why would it have such an orientation? So now when I look at this carefully, what do I see? I see that this must be the huge pelvis which is dilated out of proportion to these calyces. So that is what tells us that this is a severe PUGO. So this is what was asked in NEET 24. So this is pelviureteric junction obstruction. So before we go on to the next topic, what is the treatment? So it's simple. We need to reconstruct this obstruction. So that is why the treatment of PUGO is going to be a pyeloplasty. All you have to do is reconstruct the pelviureteric junction. The most commonly done pyeloplasty is Anderson Hines. Okay, so that's Anderson Hines pyeloplasty. Right. So on those lines, now let's look at the approach to other cysts. Look at this one. First of all, where is the problem? Left side. You can see this left kidney has this lesion which is completely grey. Now I know what is this grey color. I can always match it and see it's just like CSF. In fact, it's just like gallbladder. So common to all three is fluid, and that's why they are the same color. So you can always use that to diagnose masses, right? So this is what is a simple cyst on the left kidney. For cysts, we have a classification called as Bosniak classification, which tells us how much is the risk of malignancy. Means if I ask you this patient has how much risk? 0. So when there's a completely grey cyst, 0% risk of malignancy. Now keep increasing the complications. Here you can see there is a small little septa in the cyst. That's Bosniak 2. If you now start to have some thickening of the septation with calcification in the septa, that is a special type which is 2F. F for follow-up. Means you want to follow up this cyst for 6 months. So 1 and 2, almost 0% risk of malignancy. All you do is reassure. 2F, you follow up. For 3, now you start to have enhancement in the septa. In 4, you have enhancement in the nodules. So 3 and 4, high risk of malignancy. Here the treatment is you remove it because there is a risk of malignancy. So you do either a partial nephrectomy or you just remove the cyst. Usually partial nephrectomy would be done. So 1 and 2, reassure. 2F, follow up after 6 months. 3 and 4, because there is enhancement, it could be cancer, remove. So this is Bosniak, which tells you the risk of malignancy in a cyst. If I see something like this, look at the ultrasound. You remember Kala, Pani. So in image A, you can see multiple black cysts in the kidney. On the CT, we can see, oh, there are multiple cysts in both of the kidneys. In fact, you could also see these similar cysts in the liver as well. So what is this now? This is autosomal dominant polycystic kidney disease. Look at the MRI of this patient. Bone is black, so MRI. Can you appreciate so many kidneys bilateral? So ADPCKD will always be bilateral, and look at the IVP appearance. Here the calyces are all compressed by the cysts. So this is what has been described as the spider leg appearance or Swiss cheese appearance on IVP, right? But they'll show you a CT or an MR to diagnose. So this is important. This is autosomal dominant polycystic kidney disease. Let's discuss this. First of all, ADPCKD, ARPCKD. Both of these are always bilateral. Autosomal dominant is going to happen in adults, whereas AR is always more severe, is going to be seen in infants, and most of these will present as, CKD, and they, do not make it beyond infancy because of renal failure. In ARPCKD, another difference is you don't see these big cysts. You see tiny cysts and their outer contour remains smooth. So they have a smooth outer contour and you see microcyst formation here. So that is what is autosomal recessive polycystic kidney disease, and it is associated also with congenital hepatic fibrosis. Alright, whereas ADPCKD, you will see multiple cysts which also, obliterate the outer contour of the kidney, and this is what is associated, very important, with Berry's aneurysm, which can rupture to form SAH. It is associated with mitral valve prolapse, and it can also lead to diverticulosis. In addition, the cyst can be present in liver, spleen, pancreas, everywhere. So Berry aneurysm is the most important point here. Mitral valve prolapse, diverticulosis. Coming to the mutation, so ADPCKD is a mutation of PKD1 and PKD2, which is polycystin, right? So the chromosome here, you can remember 4 4s are 16, so 1 is 16 and 2 is 4. Alright, chromosome 16 and 4. Whereas ARPCKD is a mutation of fibrocystin gene, which is on chromosome 6. Alright, so not very important, just you can listen to this once. So this is about polycystic kidney disease. Next, we talk about renal masses. So we'll do everything rad path about the renal tumors right here, right now. First of all, when we talk about renal tumors, the investigation of choice is a CECT. You can see all 3 of these masses are CECT. So this is CECT. Then if I ask you, what is the most common renal cell tumor? Renal cell cancer. So that is clear cell cancer, right? So that's clear cell RCC. Then if I ask you what has the best prognosis, then you will say it's chromophobe RCC. If I say what has the worst prognosis, Then you will say it is duct of Bellini, very rare type. So duct of Bellini RCC has worst. If that's not there, then clear cell RCC has the worst prognosis. Alright, so these are a few questions. One extra edge question, any RCC that you find in a child is XP11. So these are called as translocation RCCs. So in a child, you may find XP11. Usually in children, we'll think of Wilms tumor. But if it's RCC, it's usually associated with translocation. Two more points while we are discussing. If they say what is the RCC that you may find in a sickle cell trait person, that is medullary RCC. So medullary RCC in sickle cell trait. So these are a few points. One more point, which is the cancer that is associated with a history of dialysis, which is associated with a mutation in fumarate dehydrogenase, which is associated with trisomy 717. This is papillary RCC. So papillary RCC, dialysis, fumarate, trisomy. Alright, so these are a few one-liners that I have told you here. CECT, clear cell is most common, best prognosis, chromophobe, worst prognosis, Bellini, children, XP11, medullary, sickle cell, and dialysis, papillary. Alright, so this is done. Then we talk about this one here. So this is where you can see in the right kidney there's a mass, very heterogeneous. Look at the histopath. It's empty. It's clear. So this is what is clear cell RCC, the most common RCC. It's clear because it has glycogen in it, it has lipid in it, and you know glycogen is pass positive, diastase sensitive. The only thing that's pass positive, diastase sensitive. This is what has a very bad prognosis. We saw that because it can lead to hematogenous metastasis, it can lead to lung mets, skull metastasis, very vascular tumor. Okay, it is associated with which syndrome? VHL, von Hippel-Lindau syndrome. We have studied this in Dermat, right? It was chromosome 3p. So 3 VHL 3 letter, 3 masses. Clear cell RCC, you can have a hemangioblastoma in the cerebellum, and you may have FEO. So this was asked in NEET 24. So this is VHL. Then you can see there is a central stellate scar. So when you have a renal mass with a central stellate scar, this is oncocytoma. Oncocytoma or chromophobe RCC, the one with the best prognosis, right? So oncocytoma, chromophobe RCC, you will see a central stellate scar. We cannot distinguish them radiologically, but pathologically, this is what we see in chromophobe RCC. These are what have been called as plant cells. Yeah, you can see how there is a racinoid nucleus. In path, they will teach you that this is what looks as a tan colored mass on gross specimen, and there's a special stain, extra edge question. That stain is called as Hales colloidal iron. So this is Hales colloidal iron stain, and this is chromophobe RCC, plant cell, racinoid, Hales colloidal iron. Alright, this is also associated with a syndrome that's called as Burt-Hogg-Dube syndrome. But don't remember that. Just remember bird out of it. Bird has a scar. Oncocytoma has a scar. So Burt-Hogg-Dube is associated with lung cysts and fibrofolliculomas, and that tells you the gene here is folliculin gene. Yeah, so this is Burt-Hogg-Dube syndrome. Third mass. So let's say they show you this CT. How do you approach this if you don't know? You see that this is the mass, yeah? Look at the color. So can you see that it's black? What if I tell you this is negative Hounsfield unit? You're like, oh, that means it's either air or it's fat. Yeah, so now you match it. Match it with bowel air, match it with subcutaneous fat. What is more matching? Fat. So that tells me that it has fat in it. So now I look at the 4 options and I see angiomyolipoma. I know nothing about it, still I know that's the answer. Why? Because this has fat. So that's what you have to learn in radio. Learn what substance you are seeing and you can diagnose anything now, right? So this is what is angiomyolipoma. Lipoma, it's not really a tumor, it's a hematoma, right, which is associated with tuberous sclerosis. Remember in dermat we have studied TSC, tuberin, hematin. So this is where you have hematomas which form, and that's why AML is associated with seizures, adenoma sebaceum, you have subependymal nodules, isn't it? Now, because it has blood vessels, muscle and fat, these blood vessels can rupture and these lesions can lead to retroperitoneal hemorrhage, and that is what is called as Wunderlich syndrome, and this may be asked. So this is Wunderlich syndrome, RP hemorrhage because of AML. So we have learned this in TSC. We can use everolimus or sirolimus because it can block mTOR and hence decrease the hematomatous proliferation. Alright, so these are the three masses and their syndromes and a bunch of other one-liners. Then we go on to next. Now we talk about MCU. What is MCU? So MCU stands for micturating cystourethropy. First of all, micturating cystourethropy, or this can be called as voiding cystourethropy, and that tells you how we do this. So what we do here is we put a Foley's catheter in a patient and we inject around 300 ml of contrast that is mixed with saline, okay, into the bladder. As soon as you put around 300 saline, the patient will say, I'm having a sensation to void urine. So you say, all right. So now we remove the Foley's and we ask the patient to micturate or void, and you see X-ray. And you see how the bladder and the urethra would be opacified. So essentially you fill the bladder with contrast and you ask the patient to pass urine. So this is the image that you get. Can you understand? This is bladder and this is the urethra. Now let's talk about the anatomy of urethra. So this part here is the penile urethra. You can see this bulbous part. So you have to see this complete part till it tapers. This is bulbar urethra, and rest of it is posterior urethra, which is made up of membranous and prostatic, but you call them as posterior. So penile plus bulbar is anterior and the remaining is posterior, which has membranous and prostatic parts. Alright, so now I am going to show you. So this is what is a normal MCU. Now I'm going to show you two pathologies here. We have done two MCUs for two kids. So the first one is a child who's presenting with recurrent urinary tract infections, okay. So this is the most common cause of recurrent urinary tract infections in children. What is this? Look at the image, MCU. I asked the child to micturate. Instead of the contrast coming down, it's going up. So what is that? That is what is called as reflux. We are seeing that the contrast is going back into the kidney, resulting in multiple urinary tract infections. So this is what we call as VUR, vesico-ureteric reflux. So MCU is the investigation of choice for VUR. Only when the child micturates am I going to pick this up. So no other investigation can show me this. Now a lot of students can mix this with IVP. Ma'am, why is this not IVP? It could very well be. So that's why they will give you that this is MCU. They will have to write. Okay. So this is VUR. It has various grades. So you can just see this image. Not very important. One is only going to ureter. 2 is going till the kidney but no dilatation. 3 is where now there is moderate hydronephrosis, moderate dilation. 4 and 5 is where there is marked gross dilatation. But in 5 you can see how these papillary impressions are also lost. It's ballooning out. So grade 5 VUR is ballooning out. So only ureter, complete, moderate, gross and gross, ballooning. So these are 5 grades and you can see how this is gross hydronephrosis. Okay. So this is VUR. Now, any child who comes to you with recurrent UTI, what is the flow of investigations? So this is where you will remember the first investigation is ultrasound to see whether there is infection or not. Then you will do MCU in order to detect VUR, and if MCU is positive, then we do something called as DMSA. DMSA is used in VUR to detect renal scars. It's a nuclear medicine investigation. We'll talk about this today. This is renal scarring. It can show you renal scars, whether the kidney is irreversibly damaged or not. So this is the order. This has also been asked previously, the sequence. So ultrasound, MCU, DMSA. This is what is vascular-ureteric reflux. Then we look at this condition. This is the most common cause of congenital urinary obstruction. Obstruction since childhood. So this is what is PUV, posterior urethral valve. So MCU is the IOC for two three-letter words, VUR and PUV. So posterior urethral valve, as the name suggests, is a membrane which is located at the level of verumontanum, which corresponds to, the posterior urethra. So this is where it does not allow the urine to go beyond it. So you can see how it's very narrow distal to it. So this is what is a valve which obstructs the urinary flow. Sometimes it can be so severe that it can lead to antenatal obstruction. So this is an antenatal ultrasound, this is UB, and this is posterior urethra, and this is called as the keyhole sign. So this keyhole sign is an antenatal ultrasound finding of severe obstruction. And how can we treat this? So you can do an endoscopic ablation. You can go into the urethra and ablate this valve. So this was NEET 24 question, endoscopic ablation of PUV. So this is about VUR and PUV. Let's look at a bunch of other urinary bladder pathologies. So this is where you can see how the bladder looks like a Christmas tree. So this is the Christmas tree appearance of bladder. Remember pityriasis rosea, Christmas tree in the skin. Remember myotonic dystrophy, Christmas tree cataract. So this is Christmas tree bladder, where you see a neurogenic bladder because of the trabeculae. Can you see the trabeculations? This is what gives the appearance of Christmas tree. Then you can see this one where the bladder looks like a teardrop. This is a teardrop bladder or a pear-shaped bladder. This happens because the bladder is getting compressed from all sides. So what is this? This is what either represents extrinsic compression via a pelvic mass, or there is lipomatosis, fat proliferation, or there are lymph nodes. So any extrinsic compression. In trauma, this could be hematoma as well, right? So this is a teardrop or a pear-shaped bladder. Look at this CT now. You can see bladder wall calcification. So this is what we see. This has been described as fetal skull appearance. It's not the fetal skull because where's the rest of the fetus? So this is fetal skull sign that represents urinary bladder wall calcification, and this is seen with schistosomiasis. So schistosoma, hematobium, remember, goes to the bladder, terminal spine. So this is what can become a risk factor for squamous cell carcinoma of the bladder. Then look at this. This is urinary bladder stone. Just like any urinary stone, this is also calcified. So this is what has been described as a jackstone appearance. And like any other stone, you can see how on ultrasound I can see posterior acoustic shadowing. So this is UB calculus. They had asked, is this UB calculus? So they gave the history. This is a PYQ, FMG PYQ, where they gave that this is a postmenopausal female and this is the X-ray. First of all, a bladder stone would be in the center. It won't be off midline like this. Secondly, you can see how this is so stippled. This is actually a calcified fibroid. First of all, now does everything add up? Postmenopausal female, alright, fibroids can undergo atrophy and can calcify. Secondly, it is off midline, means it's likely a huge fibroid which is now involuting because estrogen dependent tumor hai. After menopause, it regresses. And you can see how it is stippled. So this is what a calcified fibroid versus stone looks like. Alright, so with this we finish GU imaging, right? Now we are going to go into thoracic. Super important, lots of stuff to do in X-rays, right? So that's what we will start next. So in thoracic radio, chest x-ray is what is going to be our center, right? So in a chest x-ray, first of all, you already know right and left. You already know that the lungs are supposed to be black. So the first thing is, the moment you see any opacity or anything which is white, that's 100% the abnormality, right? So now we have to see the pattern of that. So the first thing we are discussing, very relevant to surgery and trauma also, that's where we have discussed this, pleural effusion versus pneumothorax. So both are pleural pathologies where the pleura has either a lot of fluid, which may be blood or fluid. So if it's blood, we call it hemothorax. If it's fluid, it's more medicine, it's hydrothorax. But radiologically, we don't discriminate. So hemothorax, hydrothorax, everything is going to be the same appearance. Pneumothorax is air in the pleural space, right? So that's what are these two conditions. Let's look at the appearances. As you know, fluid will appear white, air, pneumothorax, will appear black. So let's see this. First of all, what is the condition? You can see on the left side there is white, and you can see how it has this meniscus forming. So this is what is called as the meniscus sign, and that is what is a sign of pleural effusion, right? When I am sitting or when I am standing in an erect position, the fluid will first gravitate down, and this is what is going to cause the blunting of the CP angle. So this angle, which is the costophrenic angle. So there are two CP angles. This is what is called as costophrenic angle between the chest wall and diaphragm, and this is what is called as cardiophrenic angle. Yeah, so it's the costophrenic angle which becomes blunted, and that's the initial finding on a PA view, right, or an erect view. So this is blunting of the CP angle. Obviously, any pleural condition, it's going to push the mediastinum to the opposite side. So we may see a contralateral mediastinal shift. So whichever side is the fluid, the mediastinum gets pushed to the opposite side. Most sensitive investigation, fluid. What do you think? Ultrasound, correct. So ultrasound can detect as much as 5 ml of fluid. Very little. If I ask you most sensitive, X-ray, then that is going to be whatever side the fluid is. You make the patient lie down with that side down. So you can see here, this is what we call as lateral decubitus. You are lying down on a side and the fluid gravitates. So this is what is the most sensitive X-ray. So this is lateral decubitus. So can I say ipsilateral, whichever side the fluid is, make that side down. And this can detect as much as 25 to 50 ml of fluid. So that's the sensitivity, right? So this is pleural effusion, hydrothorax, in trauma, hemothorax. Then we talk about pneumothorax. So now look at this X-ray. There's nothing white. So now look for which side is blacker, because that means extra air, right? So can you see on the right side how there is hyperlucency? This is blacker than normal. Why? Because normal lung may be airhead. It has air. But there are bronchovascular markings which are not there in the pleura. So that is why this looks hyperlucent, more black. Q. Why? Because there are no bronchovascular markings here. So this is what is right-sided pneumothorax. Alright. So the mediastinal shift again is going to be contralateral shift. But for pneumothorax, air is the enemy of ultrasound. How do I diagnose it? I diagnose it on a CT scan. CT is the most sensitive. And what is the most sensitive X-ray? It is going to be expiratory X-ray. Do you remember this? First one, foreign body aspirated, right? So air trapping. Can I again say same logic? I want the normal lung to be whiter, so that this air can be seen better. So again, one more place where I'm doing expiratory chest X-ray, so that air, extra air, abnormal air can be better picked up. Right? Now, I said air is the enemy of ultrasound, but still there is a role of ultrasound in diagnosing pneumothorax when we talk about EFAST, isn't it? How is that so? That's because I'm not really trying to see air. What I'm trying to detect is M for motion. So this is a special mode of ultrasound called as M mode ultrasound, which can detect pneumothorax. So first of all, I'm going to show you what is the meaning of M mode ultrasound. Look at this. Can you see how there is this white line that is moving? Yeah. So this is what we call as lung sliding, right? So this is what the pleura looks like when it is sliding. So in a normal lung, so this is what is a feature of a normal lung or lung sliding. Now look at this image. Can you see how there is sliding which is present in this part? Show this again. There is sliding which is present in the upper half, but there is no sliding on the lower half. So this is what we call as the lung sliding sign. So now look at this point here. Okay. Now look at this. Till this point there is sliding, and below this point there is no sliding. So this is what is called as lung point sign, that there is pneumothorax which is there where there is no sliding. Alright. So this is what we need to learn here. So that was B mode ultrasound showing sliding and lack of sliding. On M mode, so this is a special mode of ultrasound where I can detect motion. So these are lines, and then this is the granularity. When we see this appearance, it looks like a seashore to some people. So this has been called as the seashore sign. Tell me, when would you go to Goa? After your exams or right before your exams? After your exams, right? So we go to Goa during normal times, means beach, seashore. Kab jayenge? Normal times. But if you just see lines, compare these two, because otherwise they look the same. Yeah? So there is a gradation here, but there's no gradation as such here. So this is what is called as barcode or stratosphere sign. Don't remember both, right? Just remember seashore is normal. So barcode or stratosphere is a sign of pneumothorax. Alright. So seashore sign, normal lung is what you need to remember here. Alright. Apart from this, can I also add on a B mode, if there is sliding movement which is present, it is normal, and if there is loss of sliding on B mode, that is also pneumothorax. So that is the role of ultrasound in pneumothorax. Right. Now let's learn about this approach. So this is the approach to opaque hemithorax. Alright, so this is where in all of these three images there's a white patch. What you have to do is you look at the mediastinum. Alright, so we look for mediastinum shift. Look at the first one. Can you say right side is white and the mediastinum is getting pushed to the opposite side? Contralateral shift. What do you think? This is pleural effusion, right? Massive pleural effusion which is pushing the mediastinum to the opposite side. So this is either massive hemothorax or massive pleural effusion where complete hemithorax is white. Then we look at the next image. This is where you can see that the left lung is white, but now the heart and the trachea is being pulled to the same side. What do we call? Ipsilateral. Jahan pe white hai, usi side. Wherever there is the white lung, that side, the mediastinum is getting pulled. So what is this? This is complete collapse. Remember, when there's complete obstruction, this is where we will have collapse. So in a child, always consider a foreign body as a cause. If it's an elderly patient, particularly they'll write smoker, think of cancer, right? CA bronchus. So this is what causes collapse. And where you see there is no shift, there is a white patch. This won't be the whole lung, but one lobe usually. So where you see that there is one lobe which is white, but the mediastinum is right in the center, this is a consolidation. What do I mean by consolidation? This is where the alveoli is filled, but the airway or the bronchus is normal. So what is the alveolus filled with? It could either be pus representing pneumonia, it could be fluid, then we call it edema. So this is what is the consolidation. So opaque hemithorax, see the shift. Contralateral shift, effusion. Ipsilateral shift, collapse. No shift, consolidation. Right? Then let's do one more approach whenever we see this level. Air fluid level. See this glass. So whenever we look at anything where you have air and water, can you appreciate how there is a solid level? There is a horizontal level. So whenever air and water are in a closed compartment, we are going to see air fluid level. So look at this one. This is where you can see one round lesion with a horizontal air fluid level. This is abscess. This is a lung abscess with air fluid level, needs 24 question. Then look at this. This is where complete hemithorax has an air fluid level. And what does this mean? Upar, there is pneumothorax. Niche, there is fluid. So this is hydropneumothorax. So hydropneumothorax, air fluid level in the pleural cavity. Now look at this. Is this hydropneumothorax? It's not. This is below the diaphragm. So then I remember, oh, this is my normal stomach air fluid level. So what is the stomach doing in the thorax? So this is what represents a diaphragm injury. So this is also an old AIMS question where they had asked, what is it that you will not do here? And the answer was ICD. Very smart question, because if you've just read superficially, you'll think, oh, this is hydropneumothorax. But no, this is the stomach which has come up because the diaphragm is injured and it's getting herniated into the thorax. So this is stomach in the thorax. Don't put an ICD, you'll further cause stomach perforation, isn't it? So ICD contraindicated. On a similar line, again the stomach gas is missing and it is in the midline. What is this? This is hiatal hernia. Remember Schatzki ring, we saw sliding hiatal hernia where G junction comes up, but this is where the complete stomach fundus is up. So what is this? This is what we call as the rolling type of hiatal hernia, where it's not the G junction but the fundus which comes up, and this is less common but bad prognosis because this has a higher risk of volvulus. Yeah, if we do a CCT, can you see I've given oral contrast and you can see how stomach has come in the same plane as the heart and the liver. It's getting pulled up, right? So this is what you are actually seeing, the stomach coming up. Hence we can see a retrocardiac. This is described as a retrocardiac air fluid level. Behind the heart there's an air fluid level. So I just erase this, see for yourself. Can you appreciate? Or you can see yahan pe missing hai, it's not here, it's come in the center. So 4 DDs, pulmonary abscess, hydropneumothorax, diaphragm injury and hiatal hernia rolling type. Okay, so this is what we have done here. While we are talking about this volvulus, because I may not talk about this again, I'll tell you right here, right now. So when we talk about this gastric volvulus, means the stomach is getting twisted upon its own axis. This could be of two types. One, it could happen along the axis of the organ itself. This is called organoaxial volvulus, or it could be perpendicular. So this is organoaxial type of volvulus and this is mesenterico-axial type of volvulus. Out of the two, organoaxial is more common, vowels, right? There is also a triad here for volvulus which is called as Borchards triad. Okay, so this Borchards triad, remember, consists of acute pain abdomen, epigastric pain. There is retching and you cannot pass NG tube because the stomach is twisted. So inability to pass NG tube, pain abdomen is obvious, retching is obvious, right? So pretty obvious one, just the name is not obvious, Borchards triad. So this is all about volvulus. Now, don't mistake this horizontal air fluid level with this image. So this is where, look at this, a better one I'll show you. There is a cavity now with a fungal ball. So air fluid level was horizontal. If you see a rounded air crescent, now can you appreciate that this is what is a fungal ball? Right, within a cavity there is a ball of aspergillus and this is called as aspergilloma. So I am showing you all the aspergillus manifestations in one slide so that you don't confuse them. So fungal ball aspergilloma is a very benign condition, as in it's not invading. There's space in the cavity, aspergillus comes and lives, right? So that's an aspergilloma and this is what is called as either the monod sign or sometimes air crescent, but monod is what is better. So this is what is the monod sign. Aspergilloma, nothing to do, you can just give symptomatic treatment. More importantly, no need to give any antifungals here, right? So that's done. Then look at this one. This is where you can see how this looks like a hand, right? So this is what is called as finger in glove appearance. There is bronchiectasis and there is mucus filled with bronchiectasis. So this is what we see in ABPA. allergic bronchopulmonary aspergillosis. So this is not aspergillosis fault. This is our body's fault which is inducing a type 1 hypersensitivity against aspergillus antigen. So you will see all such manifestations: allergy, eosinophilia, type 1 hypersensitivity, right? So this is ABPA and this is finger in glove. You see bronchiectasis with mucus. This mucus on a CT is called HAM, high attenuation mucus. It is so white, some people have called it like white Colgate toothpaste sign. All right, so that's ABPA. So two things where aspergillus was not at fault really, but this one it is, and this is where the most common cause is neutropenia, right? Chemotherapy. This was asked November INI 2025. So this is where you have a patient who has neutropenia and now develops fever. So anytime somebody says febrile neutropenia, think fungal pneumonia. What is this? So this is where we are seeing multiple nodules, and can you see one hazy shadow? That's called GGO, ground glass opacity. So where we see there is a solid nodule and surrounding that solid nodule is a halo. This is halo sign, and this is what is indicative of invasive aspergillosis, because this is where now the aspergillus is invading into blood vessels, causing this hemorrhage and hence this halo. All right, so this is the one where I will have to treat, and what is the drug of choice? Voriconazole, right? So this is what happens in immunocompromised patients: neutropenia, HIV/AIDS, halo sign. Another one, brother of aspergillus, is mucor, isn't it? So now look at this. Can I say this is reverse halo sign, right? Also called as bird's nest sign, also called as air crescent sign, where there is crescent of air bubbles inside. So you can see this periphery is solid, but the center is hazy. So this indicates mucormycosis. Again, mucormycosis, immunocompromised patients like COVID-19. Here, the treatment of choice will be amphotericin B, liposomal amphotericin B, right? So this is what we need to remember from these fungal infections. Then we talk about something that was asked in NEET 25, collapse versus consolidation. See, in both of these, it's white that the X-ray is going to become, because either the alveoli is opacified because filled with something, or it does not get air and that's why it's white. The only difference is collapse has volume loss, right? So the hallmark of collapse is because it's like a balloon which is deflated. So either you replace the balloon's air with water, that's consolidation, or you deflate the balloon. The net result is air is gone, right? So it looks white. So that's the concept. But pichka hua balloon or deflated balloon is what is going to have volume loss. So that's what I try to look at. How do I know volume loss? I see the fissure displacement. So now I want you to look at this horizontal fissure. This is how it should be. This is where it's bulging down. This is where it's pulled up. So if I ask you out of image A, B and C, what looks like collapse to you? C for collapse. Very good. So this is where the fissure has come up because the right upper lobe has become so small. So this is what is right upper lobe collapse. Yeah, and A is what is right upper lobe consolidation, where the alveoli is filled with pus. And not just that, if you look very carefully, there are bronchi also which are present. So this is air bronchogram. Look at this on a CT. The alveoli is filled with fluid, but the airway is patent. So this is the sign of consolidation called as air bronchogram sign, and this has also been tested, right? So this is consolidation. What is going on with B? Why is it going down? It's because it's so purulent that the fissure is bulging down, and this is what we see in Klebsiella. So in Klebsiella pneumonia, two buzzwords. One is this bulging fissure. It's so purulent, so much pus that the fissure is bearing the weight of it. The second thing is you may get red currant jelly sputum. Okay, red currant jelly stools was Meckel's. This is red currant jelly sputum. Hemopsis aa raha hai. So this is Klebsiella. Now look at D. So D is what has been described as a S. Can you see how it's a reverse S? So this has been called as golden S sign. What is going on? So there is collapse, right? There is fissure which went up, but there is also a mass here. What is going on? Can you think? Imagine I tell you this is a smoker. What does that tell you? Okay, there might just be a right upper lobe bronchial mass that is causing complete collapse of the right upper lobe. So this is where you have a mass also, and that is causing right upper lobe complete collapse. So that is called as golden S. This has never been asked. If this comes, party. Okay, so this is about consolidation and collapse. Then we talk about how to localize this. Consolidation or collapse we could distinguish, but which lobe? So right upper lobe is the simplest. But what if it is in the middle or lower lobe? Then both of these are gonna overlap. They are gonna be niche. Niche means down. So how do I know if it's middle or lower? Because X-ray is two-dimensional, structures overlap. So for that, I have to see something called as the silhouette sign. Silhouette means margins. So essentially, I see the margins which are lost. So if something silhouettes the cardiac border, we say it is in the middle lobe. On the left side, there is no middle lobe, so we say it is in the lingula. But if it silhouettes the diaphragm, then I say it is in the lower lobe. So we have to see loss of margins. So look at this image. There is an opacity here on the right side. You can see that the margins with the heart are lost. So this is right middle lobe consolidation. See this one, then you'll understand this better. Can I say that the margins with the heart are very well seen? It's not middle. And I can see that the margins with the diaphragm surely seem to be lost. So what is this? This is where we have lower lobe. So this is left lower lobe consolidation. Could you understand? So now see both of them together. No silhouetting, silhouetting. Right? So silhouette positive, loss of margin with heart border, middle lobe. Silhouette positive with diaphragm but negative with heart, lower lobe. In addition, you can see there is one cavity filled with air. That is what is called a pneumatocele. When you have a cavity-like structure with consolidation, we call it pneumatocele, and that is one of the signs of Staph aureus pneumonia. The most common pneumonia is going to be S pneumonia, right? So this is lobar consolidation. You can also remember on similar lines that when you see consolidation, most common causes S pneumonia, and your atypical pneumonia like mycoplasma, legionella, these are not going to present with lobar consolidation. They are going to present with infiltrates. That's why we call it atypical. All right, so that's what we want to remember here. So this is Staph aureus ka sign. One other histories, you will have prior viral URTI. So this is what complicates viral URTI into LRTI. So that's pneumatocele. Then something very unique. Okay, so diaphragm and heart is done. What silhouettes the aorta? So this is what is the aortic knuckle, and can you see how there is this sickle of air around it? So sickle of air translates to Luft-Sichel sign. Luft means air, Sichel means sickle. So there is a sickle of air around the aortic knuckle, and LU, this is what you will remember is LU, left upper lobe collapse. Now left upper lobe is unique, or left lung is unique because there is no middle lobe, there is lingula, right? So when there is upper lobe collapse, even the middle one joins it. So only lower lobe is what is spared. So what happens? The lower lobe hyperinflates and comes and occupies this part around the aorta. So that means that the lobe which is near the aortic knuckle must be the left lower lobe, particularly superior segment. Because it's hyperinflated due to the collapse of upper lobe, we are seeing that as a sickle of air. That's too much. You don't need it. I'm just telling you, if this comes, Luft-Sichel, left upper lobe collapse. Or the other thing, aortic knuckle silhouetted by left lower lobe superior segment. Right? So these are silhouettes. Few more images for you. What do you see here? Can you see multiple markings? A lot of lines, and all of these are bronchi which are dilated and filled with air. Look at the corresponding HRCT. Normally, our vessel and bronchus should be the same size. But what happens if bronchiectasis happens? The artery remains constant and you see that the bronchus containing air has enlarged. So this is what we call as a signet ring sign, or on the X-ray, because of these linear opacities, it has been called as tram track appearance. So this is what is seen in bronchiectasis. Alright, so this is bronchiectasis. Look at this one. There is bronchiectasis. In fact, it has become cystic in a few places. And what else do you see? You see that the apex is turned to the right side. The stomach is on the right side. Before you call this cartaginer, which I know you want to very badly, always check that you are not holding the X-ray ulta. That left is here. Because you know what's the most common cause of cartaginer? X-ray ulta pakadna. So then you are so excited looking at this, you label everything cartaginer. It's not cartaginer. Always check the marker. If this is left, then you can confirm that yeah, it is dextrocardia, situs inversus, bronchiectasis. So that is the triad of cartaginer syndrome, where you have a primary ciliary dyskinesia which is associated. So primary ciliary dyskinesia leads to sinusitis and bronchiectasis. So that's just primary ciliary dyskinesia. But in addition, if I have situs inversus and I have dextrocardia, that is what we call as cartaginer triad. This was asked in NEET 24. Then you can see this very usual X-ray. This is where multiple nodules are there, cannonball. This is most commonly with metastasis. So the common metastasis would be from vascular primaries like choriocarcinoma. We studied clear cell carcinoma, RCC today. Also can happen with follicular CA thyroid, right? So these are three common primaries with very vascular metastasis. These could also represent something like Wegener's granulomatosis. It could also represent rheumatoid arthritis nodules, right? So this can be seen in multiple conditions, cannonball nodules, right? But metastasis has to be the first possibility. Then let's talk about something that most students mix up, which is pulmonary edema. In pulmonary edema, the first thing is it cardiogenic? Is it non-cardiogenic? So when it is a cardiogenic pulmonary edema, what do I mean by that? Let's say somebody's left ventricle is failing, yeah? They're not able to pump out the blood. What happens? All of that is increased left atrial pressure. What is the surrogate marker of left atrial pressure? Can I say pulmonary veins ka pressure will increase, and through that the pulmonary capillary wedge pressure will increase. So this is what is the hallmark of cardiogenic pulmonary edema, where the pulmonary capillary wedge pressure is increased, which is a surrogate marker of left atrial pressure. So what do I see? The first change that I see is the cephalization of pulmonary veins. Means the upper lobe pulmonary veins are gonna increase, right? Normally because of gravity, lower lobe gets more blood, upper lobe pulmonary veins get less blood. So here first thing I'll see is upper lobe pulmonary veins getting a lot of blood. Alright. As it keeps increasing, now the next change I'm gonna see are what are called as curly lines. Curly lines are nothing but the peripheral pulmonary veins. This is what we say as interlobular septal thickening. These are the peripheral pulmonary veins which course in the interlobular septa. So look at this. Can you see how there are these lines which are perpendicular to the pleural surface? This is what we call as curly B lines. So it's curly B lines, B for base, which are more constant. These are most commonly seen. We may also have curly A lines which are near the hilum, but it's always B which is very easily seen. Okay, so this is curly. As the pressure keeps increasing, now it reaches the lungs. Now the fluid goes to the lungs, and this is what is called as edema, pulmonary edema, and this presents as bat wing sign. So this is where we are going to see that the pulmonary edema, the lungs develop consolidation, and that is around the heart. Perihilar. We may also see pleural effusion, right? So we may also see pleural effusion associated. A special type of pleural effusion. Look at this. At first look, it looks like a tumor, isn't it? But when you look carefully, you see that, oh, this is that horizontal fissure which is looking like it has collected some fluid. So, pleural effusion doesn't just go into the CP angle, it also goes along the fissures, because fissures are also pleura. isn't it? So that is where once the effusion resolves and some amount of effusion is left behind in the fissures, it looks like a pseudo tumor. So this is what is called as a phantom tumor, which is nothing but a loculated effusion in the fissures. All right. So this is nothing but fluid. It's not a tumor. That's why it's called phantom tumor. It will disappear if you give some diuretics. Right. So that's very interesting. So this is pulmonary edema, cardiogenic. What do I mean by non-cardiogenic pulmonary edema? So non-cardiogenic pulmonary edema matlab ARDS, acute respiratory distress syndrome. So ARDS, as the name suggests, is non-cardiogenic. This is usually going to have a systemic cause, for example, sepsis, pancreatitis, inhalation of toxins, right, burns. So systemic causes where we will see peripheral, multifocal opacities. This is not going to be central. So peripheral hoga, there will be no curly lines, there will be no effusion. So this is how we will distinguish. If I do the pulmonary capillary wedge pressure, completely normal, right? So we'll talk more about ARDS and its management when we go to respi, but you should know the radiological difference between the two. Right. So now we talk a little about cardiac silhouette, right? We've talked a lot about seeing lungs on a chest x-ray, but we've completely ignored our heart. So what to do here? First of all, you need to know what heart borders are made by what structure. Right heart border. The main constituent is the right atrium. And what opens into right atrium? So we have some contribution from SVC and IVC. So I'm talking about the heart border on the x-ray. Right? What is the heart border or what chamber forms the base of the heart? That is right ventricle. Okay. Then let's see the left heart border. So this part here you saw was aortic knuckle, right? So this is the aorta, aortic knuckle. Then what you see here as this horizontal part is pulmonary artery. So this is the part we call as AP window, window between aorta and pulmonary artery. Then you can see this part here, a little contribution comes from the left auricle, not the left atrium. That's the left atrial appendage or auricle that contributes, and majority of it is going to be from left ventricle. So what I can see through this is left atrium does not play a role, and we had seen that LAs are posterior heart chamber. So left atrium is posterior, does not contribute to any heart border. But if somebody has mitral stenosis and the left atrium enlarges, then what will I see? So let's study the signs of mitral stenosis or left atrial enlargement. The first thing that you see as the left atrium enlarges is now starts to impinge on the heart border. Which one? Right. And that's the question they test you with. They will mention both double right heart border, double left heart border. What does it do? It makes a double right heart border, which means I have my original right heart border. In addition, we can see that the left atrium also plays a role. So that's double right heart border. The second thing that we see is straightening of the left heart border. So this left auricle or this appendage also enlarges such that it comes into the same line as the left ventricle. So what happens to the left heart border is it gets straightened. So straightened left heart border. The carina, which is the division of the trachea, also gets splayed because the left atrium is pushing it. So that's the third sign that you see, which is splaying of the carina. And because left atrium is behind, it will push the esophagus. You may have dysphagia. It may also push on the recurrent laryngeal nerve behind, leading to hoarseness, and that is called as Ortner's syndrome. So these are the different signs of mitral stenosis or left atrial appendage. Then look at this X-ray. Can you see how there is a white shell? What does that represent? That's chronic calcific pericarditis, right? So this is where you can see calcification of the heart, and this is what has been described as egg in cup sign, right? It looks like heart is in a cup. Look at this one, the heart overall looks much bigger, and the reason is fluid. So this is what is called as pericardial effusion. It could be called as tamponade if it accumulates faster. So these are clinical diagnoses. For us, I will see both of them as expanded heart cardiomegaly, but overall heart it's bigger on the X-ray. So this is effusion or tamponade depending on the rate in which it fills, and this is called as a water bottle or a leather bottle sign. Heart looks like a bottle. So I said heart looks bigger, means what is normal? So this is where something called as cardiothoracic ratio comes in. So look at this, how we measure is I measure the maximum diameter of the heart and I measure at whatever level what is the maximum dimension of the thorax. So this heart should be less than or equal to 0.5. So 50% of the thorax should be the heart. If it is more, look at this, it is far more, that is cardiomegaly, right? So that's called cardiothoracic ratio. Another thing which I want to show you here, look at this. This is what an echocardiogram looks like. Remember kala pani? Any fluid I go to ultrasound, echo is ultrasound. Can you all appreciate? This is the heart, and around the heart, see the beating heart, around it is kala fluid. This is what echo of pericardial effusion looks like. Next, we look at popcorn sign. So there are three things where we see popcorn sign. What is the first one? This is mammography. We have seen it in surgery. This is fibroadenoma. If you see it in the lung CT, popcorn calcification, this is what is a pulmonary hematoma. It is the most common benign tumor of lung. It is also called as pulmonary chondroma. Chondro matlab cartilage. It's a cartilage tumor. Most common benign tumor. We have studied this with Carney's triad, right? So this is Carney triad where you had GIST, pulmonary chondroma, paraganglioma. I'll write it. GIST, pulmonary chondroma and paraganglioma. This is an extra edge one in the brain MRI. Why MRI? The bone is black. So this is an MRI where you see something like popcorn. This is a cavernoma. Cavernoma or a cavernous hemangioma. It's because of the blood that it looks like a popcorn. The last one, here you can see multiple spotters, right? So this first one is a child who's presenting with dysphagia. Because of the dysphagia, I did a barium and you see there is a posterior indentation on the esophagus. Somebody is pushing the esophagus from behind. Yeah, so we did a CT scan and you can see what is pushing. So this is the arch. Remember this plane, arch, SVC, T4, right? So this is where we never saw this structure. So this is where there's an aberrant vessel coming from behind the esophagus and compressing it. So this is what we call as ARSA. It is the most common aortic arch variant. So this is aberrant right subclavian artery, where right subclavian artery, instead of coming from the brachiocephalic, comes from the aorta from behind and pushes the esophagus, and that is why this is called as dysphagia lusoria. All right. On the other hand, look at this and tell me, what do you think? Now there are two arches, right side arch bhi hai, left side arch bhi hai, giving rise to two vessels each. Right common carotid, right subclavian, left common carotid, left subclavian. So what is this? This is what is called as double aortic arch. So this is double aortic arch. Alright, this is also an aortic arch variant. So this has never been asked so far. ARSA was asked in 2024 in INICT. This was asked in FMG exam. This is eggshell calcification. Eggshell calcification of lymph nodes, meaning peripheral calcification of lymph nodes, is seen in three conditions. One is silicosis. Second is sarcoidosis. And the third one is post-treatment, post-radiotherapy of lymph nodes. So this is eggshell calcification. This one, you can see how the pulmonary artery is so prominent. This is the hilum, right? The hilum has pulmonary artery as the most important constituent. And you can see suddenly it tapers off. So this is what is a sign of pulmonary arterial hypertension. It looks like a handle. So this is jug handle sign, where the pulmonary artery in the hilum is very prominent and suddenly tapers, right? So that's what are some signs that you want to know overall. So now we start with neurorad. Alright, so in neurorad, my primary focus would be again on brain brain tumors, right? So a lot of head trauma, in fact, everything in head trauma we'll cover in surgery itself. So brain tumors, everything, RAD path, I'll teach you here. Before that, some points about stroke. So again, the clinical part of stroke, we'll do it in integrated neurology, but few images that I need to show you. So what did I tell you about the approach to stroke, right? That the first investigation that we usually do is going to be non-contrast CT, and the whole idea is, look at this image. The whole idea is that acute hemorrhage is very well seen. So if it is not a hemorrhagic stroke, it is ischemic stroke. Let me not see it, doesn't matter. But if I can rule out hemorrhage, it's done, right? So that's our strategy for NCCT, that I look out for hemorrhage and I rule out. If that's not there, it's ischemic stroke, right? So that's one. The best investigation though, the investigation of choice, or they may write the most sensitive to pick up stroke, is obviously diffusion weighted imaging in MRI. So that's another point. Then they can also ask you a targeted question on penumbra imaging, which we have covered in neuro as well. Penumbra means a salvageable area. For that, the investigation would be CT perfusion, P for P, right? And we do a CT angiography to look for the vessel which is occluded. So CT angiography and CT perfusion are usually done together for a penumbra assessment. Alright, so this is done. Now let's look at the images. First of all, this is a CT, right? Bone is white. Let's look at the anatomy here. So this we have done in ANAT as well. So you can see this is the caudate nucleus, yeah, along the lateral ventricle. Then you can see this is the lentiform nucleus, like a lens, with the outer putamen, inner globus pallidus, right? And you can see this central third ventricle, this white dot is what? This is the pineal gland, okay, in the third ventricle. So on the two sides of the third ventricle lies the thalamus. So in between we have the internal capsule. So in this I can see that there is a bleed in the lentiform nucleus. The most common site of this bleed happens to be putamen, right? So this is what is called as a hypertensive bleed or a gangliocapsular bleed, and happens in patients who are hypertensive. The most common site is the putamen, and the vessel that is affected is called as the Charcot's artery. So this Charcot's artery is nothing but a branch of MCA. It is the lenticulostriate branch of MCA, meaning the branch that supplies the basal ganglia. So it's this vessel which ruptures because of hypertension and leads to bleed. The important part of this is this results in a dense hemiplegia, isn't it? This is where the internal capsule goes, and you know, in the posterior limb of internal capsule is where the complete body's corticospinal tract lies. So that is why these bleeds are so dangerous. One bleed, small part posterior limb gone, and complete half side of the body, contralateral hemiplegia will result. So in this patient, because it's a left gangliocapsular bleed, will have right hemiplegia, right? So this is a hypertensive bleed. On the other hand, when you see no hematoma, this is ischemic stroke. So this is not in the acute stage. Acute stage could be normal. So this is as it develops, you know, subacute, chronic, around 24 hours later, you see this edema, hyperdensity. They have asked here, this is a PYQ, what is the vessel? So obviously this is the MCA territory. Aage frontal lobe is ACA territory. This is PCA territory. So this is what is an MCA territory ischemic stroke. In the early stages, right, within 24 hours, one sign that you can see is this hyperdense MCA sign. So this is where you can see the thrombus within the MCA. MCA, you know, goes to the lateral sulcus. So that acute thrombus appears white. So this hyperdense MCA sign is an early sign of an MCA stroke. This, on the other hand, is also an ischemic stroke, but now in the basal ganglia. So this is lacunar stroke. So the same Charcot's artery which was rupturing there now becomes ischemic here. So this is a basal ganglia ischemic stroke instead of hemorrhagic stroke, and it's called a lacunar stroke. This is a venous stroke. Now, what do I mean by venous stroke? This is where you have a venous sinus thrombosis instead of an arterial thrombosis. So, this is where I have done a CECT. You can see how the dural venous sinus is the superior sagittal sinus here, which is white. But here I can see one triangle that is empty. So, this is what is called as an empty delta sign, and it represents a thrombus within the superior sagittal sinus. So this is superior sagittal sinus thrombosis. So various pictures or images showing different types of stroke. Now we go into complete approach to brain tumors. The first thing that you will see is adult hai ki child hai. If it is an adult, four important spotters. The first one, this happens to be the most common benign tumor in adults. What is this? This is what is first of all more common in females because this has progesterone receptors. What are we talking about? This is where the hallmark is a tail. Can you see how it's arising from the dura and it's showing a tail? So this is called as the dural tail sign. That's the first learning point. This is a mass which can also show you calcification on CT. It can show hyperostosis. The bone can become thick, and histopath. What are these? These are samoma bodies. So what is the diagnosis? Correct. This is a meningioma, right? So this is where we are discussing meningiomas. So meningioma, samoma bodies. Then we go on to the most common malignant tumor. This is what is a grade 4. Look at the degree of necrosis, and this is crossing the midline. That is why this is called as a butterfly glioma. It can cross the midline. That's how aggressive it is. What is this? This is GBM, glioblastoma multiforme. Nowadays we only call it glioblastoma. Here, I want you to remember one thing in glioblastoma. This is what is IDH wild type. Wild type means non-mutated. So here being non-mutated is bad. So wild is bad. Remember that. Alright. So this is very aggressive, very minimal 5-year survival. Almost close to 0 5-year survival. Right. So this is glioblastoma. Nowadays we use a drug called temozolomide, which we have learnt in pharma under alkylating agents, which has improved survival markedly. Okay, pathwise you can see this is called as serpentine necrosis in the center, and in the periphery we see the pseudo palisading. True palisading, where did we study? That was basal cell carcinoma. So this is where they are stacked one over the other, but not really. So that's why it's called pseudo palisading. So this is GBM or glioblastoma. Then we talk about this one. This has not been asked so far. So this is a lesion, again, common in young adults, and you can see presence of calcification. Yeah, frontal lobe mass with white calcification on CT. So CT will do in brain tumors only if I want to see calcification. Otherwise, you know, for brain tumors, our investigation of choice is MRI, right? So what am I talking about? I'll give you a hint. The genetics of this patient is IDH mutant, which is good, isn't it? Because wild was bad. And hallmark 1p19q co-deletion. What is this? This is oligodendroglioma, and oligodendroglioma, this is what has calcification, good prognosis, and this is what is called as fried egg appearance because of the multiple, cells. And we also see something called as chicken wire capillaries. So chicken and egg both together, right? So this is ODG, and chicken wire calcification is something we have seen in bone tumors, Codman tumor or chondroblastoma. So that's calcification. I keep reminding you of these things, right? So this is oligodendroglioma. This is a rare one, never been asked. This is called as bracket calcification. You can see it's right in the midline. We have corpus callosum. What is this kala kala? Black is fat, isn't it? So this is fat. Can't be air inside the brain in the very center. So this is what is a corpus callosum lipoma, and this sign here is called as bracket calcification, right? So that's all I want you to see. This is white bracket calcification in a corpus callosum lipoma, just for extra edge. Then we go into brain tumors in children. So adults में most common benign was meningioma. Most common malignant was glioblastoma. In children, the most common benign tumor is what? Look at this. This is in the cerebellum, right? So in children, most of the tumors are infratentorial, below the tentorium cerebelli, right? So this is what is within the cerebellum, and you can see there is a cyst with an enhancing nodule. So this is a cyst with a nodule that's enhancing. What is it? This is pilocytic astrocytoma. So pilocytic astrocytoma, again, good prognosis, grade 1 tumor. And what you see here on path are these pink fibers called as Rosenthal fibers. Okay. Remember VHL? We studied it today itself, right? So VHL had cerebellar hemangioblastoma, and that also will look just like this. So you have to see the age. Whenever you see cyst with mural nodule, agar child hai, pilocytic astrocytoma. If it is an adult, think of hemangioblastoma. Exact same appearance, right? So that's the DD for a cyst with mural nodule. Alright, so that's pilocytic astrocytoma. What is the most common malignant brain tumor in children? So this is what is located in the fourth ventricle. Can you see behind the pons and in between the cerebellum? So this is fourth ventricle. So this is medulloblastoma. So if I show you two path images, can you tell me which one corresponds to medulloblastoma? So what are these? These are what we describe as rosettes. Rosette of cell with center pink material. A true rosette is whose center is empty. So here nothing is empty. You can see how there is pink material. So this is what we call as Homer-Wright pseudorosette. Whereas here there's a blood vessel. This is what we call as perivascular pseudorosette. So Homer-Wright pseudorosette is what we see in medulloblastoma, whereas perivascular is what we see in ependymoma. Both of these have the same appearance. So most common malignant, Mercer malignant is medulloblastoma. Alright, so that's what we need to remember, and not just that. Medulloblastoma, remember, can also have so much drop metastasis. So it can go and line the complete spinal cord, and that is why we have to give prophylactic craniospinal irradiation. So there are 3 tumors where even though I don't see metastasis, still we give prophylactic radiation because the metastasis propensity is so high. One is medulloblastoma. Second is small cell CA lung, very aggressive cancer of the lung. And the third possibility is ALL, which spreads to lung. So actually, if you just remember small, you can remember everything. Small cell, medulloblastoma, ALL. Yeah, so small. So this is MB, medulloblastoma. Out of medulloblastoma, medulloblastoma is more in the roof, whereas ependymoma is more in the floor of fourth ventricle. Medullo is grade 4, right? Very aggressive. So you have to give it more respect. You keep it on the roof. That's how you can remember. Then you can look at this one. Very, very important. Here the buzzword or the buzz letter is C. This would be a child. All of these are children on this page. You have calcification. You have a cystic mass. This is also going to compress the optic chiasma. Optic chiasma compression leads to bitemporal hemianopia. So this is craniopharyngioma. Alright, so craniopharyngioma is a suprasellar mass. It happens above the pituitary. Look at this MRI. This is the pituitary, and in the next page I'll show you a bunch of pituitary lesions. So this is the sella. You can see how there is a cystic mass with peripheral enhancement above the sella, and that shows calcium, right? So this is craniopharyngioma, and not just that. This lesion, this cyst is filled with wet keratin and a gross specimen that gives us a hot machine oil kind of appearance. On that note, let's do all pituitary lesions now. So what happens when there is a stalk transaction? This posterior pituitary will not receive these hormones, right? So that is what is called as an ectopic posterior pituitary hotspot. So either the hotspot is missing or it's displaced. So that is what is a sign of stalk transaction. So you can just remember ectopic hotspot where it is not a white spot in the pituitary represents a stock transaction. Okay, and that can be seen because of trauma, it can be seen because of radiotherapy, and that results in diabetes insipidus because the posterior pituitary hormones don't come. So this is just one more picture showing the posterior pituitary hotspot, right? Then you look at this. What's going on? The sella is empty. There is no pituitary. So what is this empty sella sign? This is what we have learnt in endocrine. This is Sheehan syndrome. This is where the pituitary is missing. Sheehan syndrome, because of postpartum hemorrhage, pituitary underwent necrosis. Postpartum failure to lactate and amenorrhea. Look at this one. History बहुत important है. History, they will give you history of sudden shock. History of sudden visual defects. There was a pre-existing adenoma, but it bled. So this is what is T1 hyperintense. There are only two things which are white on T1 which are relevant to us. So T1 hyperintensity, one is posterior pituitary, but that's all right. One is bleed and second is fat. So when you see T1 hyperintensity in pituitary, can't be fat. This is what is hemorrhage, right? So this is what is pituitary apoplexy. This is where there was a pre-existing adenoma, but that suddenly bled, resulting in complete hypopituitarism, which resulted in shock. And because the optic chiasma got compressed, there's a visual defect. This is what is a small lesion. Can you see one small lesion? This is the pituitary, and the two black dots are the ICAs. Internal carotid artery in the two side cavernous sinus, right? So when you see that there is a small little lesion, this is what we call as a pituitary microadenoma. So this is a pituitary microadenoma. This is where now the pituitary has grown so much. This is pituitary macroadenoma, and this is called as the snowman sign because the diaphragma sella is what obstructs it here. There is a membrane which obstructs, and that's why it assumes this figure of 8. So what all did we do for pituitary? We saw normal, we saw ectopic hotspot, empty sella, apoplexy, micro-macro, and we saw craniopharyngioma, child. All of these will happen in adults. Alright, now we talk about the next category, which is CNS infections. So brain infections, different patterns that we have to observe. So look at this. This is where we can see ring enhancing lesion, and this is DWI. How to recognize DWI? You will not see the rest of the brain. The bone is missing. So this is what is a brain abscess. NEET 24 question. So this is brain abscess, ring enhancing lesion, or there can be diffusion restriction. So this is diffusion restriction. Ring enhancing means the wall is enhancing but the center pus is not enhancing. Alright, then look at these images. So this is where now there are multiple ring enhancing lesions, and this would be described as conglomerating. Conglomerating ka matlab hai they are all merging into one another. The hallmark which has been twisted twice or thrice is MR spectroscopy. What is MR spectroscopy? This is where you see a lipid lactate peak. Okay, it is a technique of MR where you can see metabolites. So lipid lactate peak suggests necrosis, and that is one of the hallmarks of tuberculomas. So this is where we are discussing TB in the brain. So tuberculomas, ring enhancing lesion, and this image shows us TB meningitis. This reminds you of star of death of SAH, yeah? But this is a contrast enhanced MR. So this is where these are the meninges which have become so thickened. So this is where a star of death is seen on post contrast. So this is TB meningitis, the buzzword being conglomerating ring enhancing lesion and lipid lactate peak. Then look at this. This is where they will give you in the history that this is a child who's having encephalitis, right? And the child presents with behavioral abnormality. You may also see RBCs in CSF because this is a hemorrhagic encephalitis. So this is HSV1 encephalitis, happens in children and affects the frontotemporal lobe. Can you see this happen? This is happening in the frontal lobe and this is the temporal lobe. So frontotemporal hyperintensity is what is encephalitis. right? So these are few infections. Now we talk about very, very important neurocysticercosis. So neurocysticercosis, remember, we do this Escobar staging. So I want to talk about these stages. You know the micro aspect of NCC, tinea solium, right? The definitive host of tinea solium is man, intermediate host pig, right? So that's tinea solium, and this happens because of egg of tinea solium commonly seen in unwashed, unhygienic vegetables, right? So it's not just transmitted through pork, it is transmitted through unwashed vegetables as well. So what are the 4 stages? So the first stage is vesicles, where you just see fluid filled cysts. So this is where the buzzword is T2 white. You remember T2 hyperintensity World War II. So this is white, and you can see there is a central dot in the center. So that scolex is the hallmark. Always look for this central dot to diagnose NCC, right? So this is what is neurocysticercosis hallmark, vesicular stage. In the first stage, there is no edema. If there is no edema, there are no symptoms. This commonly presents as seizures, right? So first stage, vesicular stage, no seizures. Second stage is where now you start to see the edema. Can you see? There is a lesion and then there is edema. This is colloid vesicular. This is where you have seizures. This is the maximum propensity, maximum activity this time. Now it starts to regress. So the edema is there, but it decreases. Yeah, so you may have clinical features as this time, but that is also decreasing because now you start to see some degree of calcification. Last stage is nodular calcified, where everything is calcified, right? So everything is calcified, no edema, no seizures. So this is the inactive stage, final stage. Just how we had putti kidney, this is the final putti kidney stage where everything is over. All right. So very old AIMS question they had asked, out of these 4 stages, where do you expect least chance of clinical features? Final one. It's already treated, right? On similar lines, we can plan the treatment. Because this is where you are having seizures essentially, I have to give anti-epileptic drugs. I have to give steroids to decrease the edema, and I have to give albendazole to kill the tinea solium. So everything needs to be given. In fact, first give steroids to decrease the edema, because if you first give antiparasitic drug, what's going to happen is it's going to release more edema. So that's why first control inflammation, then give albendazole, right? You can also use praziquantel. So this is NCC stages. I've gone in a little depth because you get multiple questions. Then if you have the buzzword of HIV/AIDS, so if there's a patient who has HIV/AIDS, 3 patterns. If you see the basal ganglia having these small white lesions, these are what we call as the soap bubble appearance, and this is what we see in cryptococcoma. So this is cryptococcus but not meningitis. These are cryptococcomas. So these are called as soap bubble lesions in the basal ganglia. These are also described as pseudocysts, okay, because they have this gelatinous material. So pseudocysts filled with gelatin-like material. If you see again basal ganglia involved, but this is what is called as target appearance. You are seeing that there is a central dot. Most common infection in HIV/AIDS, this is toxoplasma. Very, very important. So target toxoplasma. And if you see this diffuse white matter hyperintensity, this is PML. What is PML? Progressive multifocal leukoencephalopathy. Leukoencephalopathy tells you that it's white matter which is affected, and this happens because of JC virus. Okay, so this is PML, progressive multifocal leukoencephalopathy. So 3 things in HIV. Look at the pattern and diagnose. The last part of NeuroRad are just a bunch of signs and spotters that we need to see, right? So now just spotters. So look at this. This was asked in INI in 2024. Look at this. This is what is the cerebellar tonsil. Normally, this tonsil should be above this line. Can you see? This is called as basion, which is the lower part of this clivus bone, And this is opistheon, which is the lower part of occiput. No need to know that. Just know these 2 points. The tonsil should be above it. Look at a normal image. This is the cerebellar tonsil. This is basion. This is opistheon. Can you appreciate how it is above it? So this is normal. When you see this tonsil is down, this is what we see in Chiari 1 malformation. It may also be associated with a syrinx. Syrinx is where in the spinal cord you will see white hyperintensity. So that is in a T2 image, right? So that's associated with a syrinx. So this is Chiari 1, tonsil coming down with a syrinx. This is more likely to be asked, not been asked so far, so very potential. This is what is Dandy-Walker malformation. So Dandy-Walker malformation is where you have a posterior fossa cyst, right? You can see this posterior fossa is enlarged and it's filled with fluid. And you can see this is accompanied with vermis. Cerebellar vermis is agenetic. So you can see cerebellar vermis is absent, and that is why you have a huge posterior fossa enlargement with cyst. You see one black channel. Now remember, on MR, the blood vessels will appear black. Remember at the beginning of this video, long ago, where we had talked about how MR signal is from the protons. Now in blood vessel, the protons are moving so fast that by the time we get that signal, the proton is already left. So that is why a normal blood vessel will appear black, and that's called a flow void. So I can see a huge flow void in the center of the brain. They will give you, this is a newborn baby, a neonate who has high output cardiac failure, and there is a bruit. You can hear an intracranial bruit, blood flowing fast. So this is vein of Galen malformation. So this is what we call as vein of Galen malformation, where you have this huge vein of Galen which has arteries feeding onto it. So it's actually a misnomer. It's not a malformation. It is actually AV fistula, where the arteries open into this vein and this vein becomes dilated. So that is why it's a high output cardiac failure, because a lot of blood is going into the veins very fast. Alright, so that's vein of Galen. If you see this is where you can see something called as a puff of smoke disease. This is a DSA, by the way, digital subtraction angiography of the brain. This is the carotid, and suddenly you see no branches but all of these tiny vessels. So this is called as Moya disease, where you can see that there is a narrowing of the ICA, because of which there are all of these tiny collaterals which develop. So buzzwords: Chiari, Dandy-Walker, vein of Galen, Moya disease. Let's look at more malformations. So this is where, look at the brain, how smooth it looks. So this is called lissencephaly. In Gujarati, we call smooth as lissu. So this is literally that, lissencephaly. The gyri and sulci are missing, right? So this is lissencephaly. It's a congenital anomaly. This is where there is a communication. There is a split. Schizophrenia, split brain. This is schizo brain, schizencephaly. There is a split in the brain and the ventricle communicates with the CSF. All of these come under neuronal migration defects. The brain is not formed properly. And this is holoprosencephaly. Holoprosencephaly means that the brain is fused in the midline. You can see a single monoventricle. There is no interhemispheric fissure. So there is a single monoventricle fused brain, also called as pancake brain, right? So this is what is holoprosencephaly, associated with Patau syndrome. Trisomy 13. In the orbit, 3 images that I want to show you. So look at this one. This is orbit. Optic nerve corresponds here. So you can see this is how normal optic nerve would look. No enhancement. Here there is enlargement and enhancement. So this is what is called as optic nerve glioma. This is associated with NF1 more commonly. This is where you can see the optic nerve, but there is a tram track appearance. Can you appreciate that there is enhancement on the 2 sides of the optic nerve? So this is what is an optic nerve meningioma, and this is associated with NF2 more commonly. So that's optic nerve meningioma. Look at this. This is where there is ethmoid, which is white. So there is ethmoid sinusitis, and now there is something which is pushing into the orbit. So this is what is a subperiosteal abscess of the orbit, and that is a complication of ethmoid sinusitis, because the ethmoid is what is most commonly communicating with the orbit. So this is a subperiosteal abscess impinging into the orbit. So these are three images. This has been asked 2 years back. These two haven't been asked for the longest time, so very probable questions. Then a few named signs, right? So this was asked last year INI. Can you see how the part of basal ganglia, first of all, which part? So this is putamen, this is globus pallidus, right? So this is where the globus pallidus looks like the eye of the tiger. So this is called as eye of the tiger sign, and this is what represents what was previously called as Halle-Warden's-Spatz disease, but then they renamed this to something even worse, PCAN. PCAN stands for pantothenate kinase associated neurodegeneration. So pantothenate kinase associated neurodegeneration, where you have iron accumulation. Actually, so this is what comes under iron accumulation disease into the basal ganglia, because of which you see this eye of the tiger sign. On the other hand, this is what is called as tigroid. So there are two different things. So eye of tiger, not same as tigroid. So this is where the white matter is abnormal and this looks like tiger, isn't it? So this is a tigroid sign that you see in metachromatic leukodystrophy. We studied this in biochem, remember? Aryl, now it's tiger time. So this is aryl sulfatase, tigroid appearance, and this is also seen in Pezilius Morsbecker. Obviously, this is an Ames question, right? So this is Pezilius Morsbecker, tigroid. Don't know why and how they asked this, but you can just remember it faintly. You look at it in the options, it will come back to you. Finally, this is the midbrain, which is looking like a panda, isn't it? So this is what is face of panda sign, which is seen in Wilson's. Where else did we see this? On a gallium scan. Here you had uptake here. That's sarcoid, isn't it? So sarcoid also shows a panda sign on gallium scan. So this is Wilson's disease. And what do you see here? So I'll just mention it. Sarcoid, gallium. This is where you can see how this is the midbrain and it looks like a molar tooth. So this is what is called as the molar tooth sign, and this is what is seen in Joubert syndrome. This is Joubert syndrome, molar tooth. Again, hasn't been asked for the longest time. So these are just some standalone brain anomalies and their findings. With this, we finish all of our systemic radio. Now, the very last part, this has been a huge, very long video because we've gone very extensive. I don't want you to do anything else for radio. I think you have realized that by now. Just solve the questions. I've covered almost every PYQ which has been asked and any potential question. So this is it for radiology, right? So now we go into radiotherapy and nuclear medicine. So first I'll teach you something about basics of radiation and why we say, radiation is so bad. So when we say that radiation is bad, it's because it is causing double-stranded DNA breaks. That's the main mechanism why it harms us, and it also helps make free radicals. So that is why free radical induced damage also contributes. Out of all the radiations, the one that has maximum damaging power or maximum ionization or transfer, linear energy transfer, is with alpha rays, because alpha rays are very heavy. They are the nucleus of helium actually. Minimum is gamma rays, because gamma rays are rays. They pass very fast. Means they would have the maximum penetrating power. If neutrons are in the option, they have the absolute maximum penetration, even more than gamma rays. But minimum would be the heaviest particle, isn't it? So minimum is alpha rays. So maximum damaging is alpha, minimum penetration is alpha. Gamma, maximum penetration, minimum damage. That's how you can remember. Effects of radiation can be divided into two. Stochastic, it's there in the name. chance. This is what happens by chance. It is a delayed effect. There is no threshold. It may or may not happen, but the probability is directly proportional to the dose. If you keep increasing the radiation dose, the probability of this happening increases. We are talking about cancer. So stochastic chance की बात है, cancer, and it's all or none, right? But deterministic is there is a threshold. If you cross that threshold, you'll get this erythema, cataract, epilation means hair loss, right? And this happens immediately. Here, the severity is directly proportional to the dose. If you keep increasing the dose, the effect becomes more and more severe, right? So this is some basic that you need to know from radiation. Then let's talk about the maximum permissible dose. So this is what is the maximum permissible dose which has been given by our Indian AERB, Atomic Energy Regulatory Board. So we follow these numbers. Overall, for general public, the background radiation, here I am talking about background radiation, okay, the limit is 1 millisievert per year. But for occupational workers, that limit becomes either 20 or 30. So if you average it over 5 years, it's 20. In a single year, 30. So remember both numbers, one of them will be in the option. If both are there, go for 30. For lens, even though you don't need to remember, it's 150 and just remove one zero for public. Skin extremities, it's 500, remove one zero for public. This is the one that I wanted to remember. What about a pregnant occupational worker? So from 20, it goes down to 2. For general public, remains the same. Fetus, we can assume, is getting half of the radiation. So 1 and 0.5. So the only takeaway from this, actually from my end, would be 3 numbers. 20, 2 and 1. Alright, general public 1, occupational workers 20, if pregnant 2. Now, how do I know how much I am getting exposed? So, all the occupational radiation workers are gonna get this badge. So, this is what is a TLD badge. So, this is what is using the principle of thermoluminescence. So, thermoluminescent dosimeter. This is what will measure the radiation dose to each and every personnel. This measures 3 monthly. So we have to submit this after 3 months and it will be recorded. You can see April, May, June. Yeah. So 3 monthly this gets submitted and it uses calcium sulfate with dysprosium as a compound. Where do we wear it? We wear it at chest level, just where I'm wearing the mic. That's where we wear it, just below the lead apron. So I'll wear the lead apron, below it I'll put this. So it will measure what radiation I'm getting exposed to. Alright, and this is the lead apron that we wear. So the TLD is worn at chest level below the lead apron. Lead apron, 2 questions you get. Most common thickness of lead is 0.5 mm. The minimum thickness that should be there is 0.25 mm, right? So that's lead apron which absorbs the rays before they reach the occupational worker. So we wear these aprons for any, fluoroscopy procedures which are video of the X-ray, or for any DSA. For DSA, this is mandatory to be worn because otherwise there is a lot of radiation because you are doing all of the vascular procedures under X-rays, right? So that's what is lead apron. Alright, so now we talk about nuclear medicine. Nuclear medicine, as we discussed, is going to deal with gamma rays, right? So that's why it's called nuclear medicine. So understand the origin. X-rays come from the outer shell electrons in an atom. So this is where, let's say this is an atom which is the nucleus and these are the shells, K shell, L shell, if you remember. So when these electrons are shed off, we get X-rays. But from the nucleus is where the gamma rays get emitted. So because this branch uses these gamma rays, it's been called nuclear medicine, right? So everything has a reason. We just don't think enough to know the reason, or we don't care enough. So this is gamma rays. Now what you need to remember is, how am I using gamma rays? So this is where we talk about scintigraphy and SPECT. So I use a compound called technetium-99m which emits gamma rays, okay, and I tag it with a compound which will take it to the site of interest. So let's say I combine this with sestamib. So sestamib is the carrier ligand which will take this technetium to a parathyroid adenoma, if any. ठीक है. So let's say one has parathyroid adenoma. I injected technetium sestamib. It will take it to the adenoma and I will see that as a hot spot. So this investigation, which is two-dimensional, is scintigraphy. So this is technetium sestamib scintigraphy. This is technetium sestamib SPECT, where in addition to this, I am giving you a CT free. That all right, take a CT scan and give a 3D localization. So this is the only difference between scintigraphy and SPECT, that in SPECT I'm also adding a CT scan. So this is called as single photon emission computed tomography, same as CT. So can I say this is definitely better? Because I get 3D localization. So that's what they asked in AIMS once. Out of sestamib, SPECT and scintigraphy, what is better? So obviously it's SPECT, which is the investigation of choice for parathyroid adenoma. Alright, so that's the principle here. How is this different from radiology? In radio, we were sending the radiation from outside. Here, the patient is radioactive. I just need to take a camera and see if the patient is emitting radiation or not. So same concept now I apply with all of these. I take technetium and I combine it with a compound which will take it to the area of interest, right? So let's talk about MDP. MDP stands for methylene diphosphonate. This is what takes technetium to the bone. So look at this. This is what a normal bone scan looks like. All of the bones have taken some amount of MDP. But look at this. This is where there are multiple hot spots. There are multiple areas which are taking a lot of technetium MDP. Alright, so this is what we call as hotspots, and this is what we normally see or would expect to see in metastasis. That's the primary indication. We can also see this in primary tumors. Alright, so this is what are hotspots, multiple bony metastasis. Very important, where would you use a triple phase bone scan? Where you check flow, blood pool and the bone phase. So that's acute osteomyelitis. Do you agree? There also there is more bone turnover, bone formation. So there will be uptake by MDP, but because it's inflammation, I will also see the vascularity is increased. So this is a question which has not been asked, party question, that if they ask triple phase bone scan kahan karenge? Where will we do this? Osteomyelitis. Cold spot is multiple myeloma. Even though there are lytic lesions in the bone, they are not really showing bone uptake. It's a plasma cell tumor. So that's why cold spot is in multiple myeloma, right? And look at this now. It looks as if all the bones are taking so much uptake. So this is called as a super scan. And what is this? This may either mean diffuse metastasis, which is a PYQ, or it could mean a metabolic bone disease. So this may be seen either in diffuse metastasis or metabolic bone disease, where all the bones of the body are showing a lot of uptake, right? Then we talk about HIDA. Now HIDA behaves just like bile. Look at this. This is what is normal HIDA. We see that the bile is excreted through the bile ducts and it comes into the bowel. So this bowel opacification in HIDA scan is what is normal. Alright, so this is what a normal HIDA looks like. 3 use cases. Bile leak, I can use to see the leakage of this compound. So this happens to be the most sensitive investigation for bile leaks, HIDA. Problem kya hai? The downfall is that it does not tell me the site or the type. It just tells me that leak is there, which is kind of useless, right? So I want to know the site and type. So that's why it's theoretical, only most sensitive. EHBA. EHBA also, this is a good investigation. A lot of people can call it investigation of choice, but better put, it has very high negative predictive value. If I do not have bile duct, do you agree? I will not see bowel. So what we see here is, if I can see the bowel, I can be 100% sure it's not EHBF. But if I don't see the bowel, it could be something else also, like neonatal hepatitis. So it has a very good ruling out power. That's what you want to remember. And what will I see in EHBA? Non-visualization of the bowel. Now, if I see non-visualization of gallbladder, that is what is acute cholecystitis. Look at this. The gallbladder is so inflamed and obstructed in cholecystitis that this big round thing, you don't see gallbladder taking uptake because it's inflamed. So, non-visualization of gallbladder is a sign of acute cholecystitis, and HIDA happens to be the most accurate for acute cholecystitis. Again, theoretical. In practice, ultrasound does a great job without any radiation. Why should I do technetium, right? So this is what is acute cholecystitis. Then look at this liver mass. Can you see this is a mass with a central stellate scar? We saw kidney mass with a central stellate scar. That was oncocytoma. This is a liver mass with a scar. This is FNH, fibrous nodular hyperplasia. Okay, there is one more DD for a mass with a central stellate scar, and that is a fibrolamellar HCC. It's a variant of HCC, fibrolamellar. It has a central scar with calcification. Not very important. Just remember FNH, central stellate scar. Fibrolamellar HCC has a scar which has calcium, and there is a marker called as neurotensin, not alpha fetoprotein like HCC. Okay, so these are two DDs for liver masses with scar. Out of these two, only one shows a hotspot on sulfur colloid, and that is FNH, because sulfur colloid can pick out reticuloendothelial system. So that is why I see the presence of Kupffer cells here in sulfur colloid scan. For pertechnate, technetium pertechnate is the investigation of choice for Meckel's diverticulum. Look at this. This is where you will have a child who presents with red currant jelly stools, right? So red currant jelly stool in a child, they can ask you what will you do next. So red currant jelly stools, painless red currant jelly stools, because if it's painful, think intussusception. So this is where you do pertechnate. Pertechnate has an ability to bind to stomach. That is why it binds to Meckel's, because Meckel's diverticulum has stomach mucosa in it, right? So that is what is the rule of 2. It is seen in 2% of the population. It has two kinds of mucosa. What are the two kinds of mucosa? It has stomach mucosa and pancreatic mucosa. The size is 2 inches long. It is located 2 feet away from ileocecal junction, right? So this is what we need to remember from Meckel's. It is the only true congenital diverticulum, right? So this has all the layers. We can use pertechnate in thyroid imaging as well if iodine is not available. So normally we use iodine 123. If that's not there, I can use pertechnate. And there is a salivary gland mass which shows a hotspot, and that is Warden's tumor. So Warden tumor can show us a hotspot. These are 3 renal scans. So DMSA we already discussed will show us renal scarring, especially in patients with vesico-ureteric reflux. So look at this. This is what DMSA is. It's a picture. It's a static image where I can detect scar in the kidney if it does not show uptake. But DTPA and MAG3 show me function of the kidney. These are functional renal scans, and they show me whether there is any obstruction or not. So look at this. This is what DTPA MAG3 look like. You can see how the kidney is excreting this compound, and we can see that on this side it is not excreting. So this is what the graph looks like. We see the compound is accumulated in the kidney and then excreted, but in obstructive it could never excrete. So we see the signal from that technetium because it's constantly emitting gamma rays. So we see if that drops or it doesn't drop. Finally, captopril. If they specifically write the word captopril renography, think of renal artery stenosis. So in renal artery stenosis, you will see this captopril renography. It can further diagnose it because ACE inhibitors causes, vasoconstriction of the afferent arteriole, so that can be detected. So these are a few uses here. Now we talk about heart. Cardiac imaging, just the names we need to know. So this is a little confusing part for most students. So thallium, tetrophosmin and sestamine. These are 3 scans that we use for myocardial perfusion imaging. This is what perfusion imaging means. We can see the flow in each and every part of the heart such that if there is any ischemia, we can detect it. So this measures the perfusion. Thallium is the one that we use most commonly. Sestamine also comes here, right? Apart from parathyroid adenoma. Pyrophosphate, pyro matlab fire, fire means hot. So this is what is seen as a hot spot for infarct. This binds to infarct, whereas perfusion detects ischemia as a cold spot. You will not see the flow there, whereas this will go and bind to that. So that's pyrophosphate. FDG PET helps us in studying myocardial viability. Whether the myocardium is viable or not, it's the investigation of choice. And for cardiac function, these are the three tests out of which MRI is investigation of choice. We can do MUGA, we can do echo. Echo is nothing but ultrasound, right? So all three of these show us heart function. MRI, this is what cardiac MRI looks like, and we can do something called as delayed gadolinium enhancement. This has never been asked. Delayed gadolinium enhancement is what we see in ischemia. So, you know, this is ischemia, ischemic cardiomyopathy. If there is any insult, we will see late gadolinium enhancement. So that is what we see on MRI. So it can detect any dysfunction. It can tell us ejection fraction. It can tell us if there is any regurgitation. Everything can be detected by MRI. So these are a few cardiac scans. Now we talk about PET scan. Super important. So PET scan, what does it stand for? So this is positron emission tomography. Alright, so this is where we are going to talk about positrons. What do I mean by that? So the compound that I use most commonly is 18-FDG. First of all, this is what is a PET CT. You can see there's a CT underlying, and then you can see these hotspots. So this investigation is nothing but a hybrid of PET scan and a CT scan. Now, how is this the investigation of choice? So, you know, FDG PET is the investigation of choice for metastatic workup for any cancer in the body. So, this is where I inject this compound called fluorodeoxyglucose. 18-fluoride is our positron emitter. What is positron? Positron is nothing but a positive electron. Yeah. So, this 18-fluoride does that job, and I link it with glucose. Cancer cells are hungry for glucose because they have something called as Warburg effect. Warburg effect matlab aerobic glycolysis. Even though they have mitochondria, they can do Krebs, but they don't. They waste glucose. So they still do glycolysis, right? So that is what you need to remember here, right? Glycolysis properly. Yeah, so they are wasting glucose. That means any glucose I inject will preferentially go to cancer cells because of this, because they are wasting, they are spoiled. So now when I inject this FDG, it is taken up preferentially by the cancer cells. Now our fluoride gets to work. Once it's inside cancer cell, this fluoride emits a positron. This will combine to electrons. Electrons to bahut hai, many electrons are there. This reaction is called as a annihilation reaction, and this results in simultaneous release of two gamma rays 5 and 1 kilo electron volt each. So because of these gamma rays which are getting released immediately, we can detect in our scanner where is the cancer, because when I see two rays, I can localize where it's coming from, right? So this principle is called as annihilation coincidence principle, because there is annihilation resulting in two coincident gamma rays. So that's the concept of PET CT, and that's how we detect these hotspots and say that either this is the cancer or it's the metastasis, right? So that's what is FDG PET. Few questions here. Where do you see false negative? False negative means it's a cancer, still the PET is not showing uptake, or I can say avidity. It's not PET avid. So there are two things which show a false negative. Means even though they are cancer, still they are not showing PET uptake. So the first one is a typical carcinoid. It is so well differentiated, it still does not show. Second is mucinous adeno-CA. Mucinous variant of adeno-CA does not show PET uptake for some reason, not known. False positive means it's not cancer, still it's showing uptake is TB, right? So active TB can take up uptake because it's inflammatory. So this is something which is very important. Also, a prerequisite for PET scan is the sugar. Random blood sugar should be normal, right? Because if the sugar of the patient is diabetic or hypoglycemic, then all of this concept of cancer cells taking up glucose falls apart. So that's why the prerequisite is random blood sugar, normal or non-diabetic. Basically, the sugars must be well controlled in the patient before you do PET scan, right? That's the concept. Sodium fluoride PET is what is used for bone metastasis particularly. Choline and PMSA, this is an FMG question, is particularly for prostate. So these are more specific for these conditions. DOPA PET, DOPA is FEO, because FEO, dopamine gives rise to epinephrine, norepinephrine, so pheochromocytoma. Very, very important. DOTANOC PET is neuroendocrine tumor of pancreas, alright. And C11 Pittsburgh, very special new study for Alzheimer's. So this picks up the Alzheimer dementias, amyloid deposits preferentially. So this is what are a few specific PET scans. The last part, radiotherapy. So now I'm taking this radiation. I know radiation is bad. So what if I collect a bunch of it and throw it on cancer? Do you agree it will kill the cancer cells? So this is where I'm using the harmful effects of radiation now to my benefit to kill cancer cells. So now, where are you giving the radiation? Are you giving it from a distance? So that would mean if here is the cancer, the surrounding organs also get damaged, right? So this form is called external beam radiotherapy, where I am giving radiation from a distance. This is called as teletherapy. So external beam radiotherapy or teletherapy, the disadvantage is surrounding organ damage. That can be countered by going close to the tumor. For example, let's say one has CA prostate. You go inside the prostate and put radioactive isotopes. That is called brachytherapy. Yeah, so that is called brachytherapy. The only problem with brachytherapy is while putting the radiation, you may get exposed. So that is why we do something called as remote after loading. So this is a PYQ. Here, you will first put this empty grid and then a robotic arm is going to put the radioisotopes so you will not get exposed. So this figure was asked, brachytherapy. Right? This machine that you are seeing here for teletherapy is called LINAC. Very important. Linear accelerator. This is what makes electrons and X-rays. It's X-rays that we use most commonly as source of radiotherapy now because there's a switch on, switch off. With nuclear reactors, previously we used to use cobalt, cesium, there's no on and off switch. It will go on till its half-life, right? So the advantage here is X-rays can be modulated in terms of time and energy. So we use LINAC very commonly now. Cyclotron is particularly for protons. So this is where we use proton beam therapy and we'll talk about the advantage in a while. IMRT is intensity modulated radiotherapy. This can be asked. So this is where we, give radiotherapy according to the tumor. We mold it three-dimensionally and give it to different, areas. So you can modulate the intensity according to the tumor dimensions. Fractionated RT. Just like how we work. We work for 5 days and take break for 2 days, right? So radiotherapy also happens like that. Let's say I have to give 50 grays. I divide that into 1 gray daily. You get a break for 2 days and then again. So the total dose is divided into fractions. Now, why is that 2-day break important? That is explained by the 5-hour concept. In those 2 days, you are allowing normal cells to repopulate and repair themselves. You allow redistribution of cell cycle. We will study in a while how G2M is very sensitive, but S phase is not sensitive. So this break allows the cells in S phase to come to G2M and become sensitive. Oxygen helps radiotherapy. Can you tell me why? Because free radicals, to make free radicals, I need oxygen. So it allows for oxygenation and this explores the concept of radiosensitivity. So this can be asked, never been asked, the 5 hours of fractionation. Finally, what you see here as this helmet is the gamma knife. Alright, so this is gamma knife. It was discovered by somebody called Lexell. So this is the Lexell frame. As the name suggests, this is where I am giving a very high precision dose of gamma rays. So this is like a surgical strike on a terrorist. I know the coordinates of this tumor, X, Y, Z. So these are the coordinates. I mark it out using this helmet and give a very focused gamma ray using cobalt 60. So this is what is used for brain tumors without causing surrounding organ damage. Very well established in vestibular schwannomas, has become the first line for any vestibular schwannoma which is less than 3 centimeters. It is used in pituitary adenomas. You can use it in refractory trigeminal neuralgia. You know, the drug of choice is carbamazepine. So this can be used in refractory trigeminal neuralgia. The counterpart of this for the body is called as cyber knife. So cyber knife is what we can use, and this is what is a frameless technique. There is no Lexell's frame there. Alright, so these are your radiotherapy concepts. Now let's talk about how different radiotherapy agents behave. Okay, the mildest are electrons. Shuru hote hi khatam ho gaya is what we call this, right? That this deposits completely on the skin. Electrons. So electrons, where do I use this? So one, I can use it for cutaneous T-cell lymphoma because I want the effect on the skin, very smart. Or I can use it for intraoperatively radiotherapy. Intraop, it's already open, give electrons, superficial, right? So that's what are the use cases. Gamma rays and X-rays are like most of us. You know how in the beginning of this video I was so energetic. Now all of us are done, ma'am, kab khatam hoga. So X-ray and gamma rays, the energy keeps decreasing as you go deeper. But something is very powerful. Some of you might have slept in between and have suddenly woken up right now and you are like, come on ma'am, let's go teach more radiotherapy. So this is what is Bragg's peak. Yeah, so this Bragg's peak is what is very unique about protons, because what does that open up? That opens up the avenue that I can have effect deep into the tissue without surrounding organ damage, and that is why we use protons for deep-seated brain tumors. For brain tumors which are deep, I can use proton beam therapy, right? So that's Bragg's peak. So this is about the effect and the concept. Now all facts, 3 tables, 4 tables, facts, and we are done. So the half-lives. FDG has a half-life of 110 minutes. Technetium 99, 9 ko ulta kar do, 6 hours. Then you have 4 radioisotopes of iodine. First of all, iodine 31 emits both beta and gamma rays, whereas all of these only emit gamma rays. That's first. That's why we use this for treatment of cancers, systemic radiotherapy. Now, because 123 is the smallest number, take 1 and 3 and make it hours. Everything else is days. 124 में से take 4, so becomes 4 days. 125 do 12 into 5, becomes 60 days. 131 do 1 plus 3 plus 1 and then take 3 one more time, so that becomes 8. So that's how using maths you'll remember. 4, 12 5s are, and 1 plus 3 plus 1 plus 3. Cobalt 60, old question, 5.2 years. Don't take this table to your heart. I mean, just read it once or twice and let it go. 5.2 years. Cesium is 30 years. And radium was used previously. It's 1622 years. It used to emit alpha rays. Not used anymore because very carcinogenic, right? Plus, it's like radioactive for 1622 years. Who's going to store it for 1600 years, right? So that's why it's not used. Permanent implants are gypsy. So these are brachytherapy implants which can be put, and because they have a shorter life, you can forget about it. Permanent. So this is gypsy. You can remember gypsy, once a gypsy, always a gypsy. Permanent. So gold, yttrium, palladium, this is 131. That's the only thing, not 137. And iodine 125. So remember gypsy. Pure beta emitter, remember psyche. So pure beta, only beta rays. Phosphorus 32, this is used as a systemic radiotherapy. This is used in polycythemia vera. Strontium is again used as a systemic radiotherapy for bone mets, and you have yttrium. So PSY. Few one-liners. Most common side effect of radiotherapy is erythema, deterministic effect. Most common malignancy is AML. Brain tumor after craniospinal is meningioma. Remember dural tail sign. Most common radiotherapy-induced thyroid is papillary CA thyroid. We have studied this in surgery. And bone cancer, this also we have studied in ortho, is osteosarcoma, right? So it's resistant to radiotherapy, but it's self-caused by radiotherapy. So that's secondary osteosarcoma. A bunch of one-liners about radiosensitivity. So this is where we talk about Bergoni's law, that the cells which are constantly dividing are very sensitive, but the cells which are quiescent, not dividing, are least sensitive. The organ that is most sensitive are going to be the gonads, right? Ovary and testis. Least sensitive organ is the vagina. Don't mix it with tissue. The most sensitive tissue is hematopoietic tissue, bone marrow. But the least sensitive tissue is brain. You know, brain cells, neurons don't divide. So that can also explain the sequence of changes in acute radiation syndrome. Let's say there's a nuclear accident. What is the sequence? The first system to shut down is hematopoietic. That takes around 1 to 2 grays of radiation. Then you have GI, which takes around 2 to 10 grays. And then we have heart and brain, which will need more than 10 to 20 grays, right? So this is how the organs shut down in nuclear accidents like Chernobyl. Cell cycle phase has been asked multiple times. G2M is most sensitive. S, they love asking S is sucked, least sensitive. The blood cell that's most sensitive is lymphocyte because of its big nucleus, whereas platelet, very small, no nucleus, least sensitive. Structure of eye most sensitive is lens, that's why you have cataract. Least sensitive is the sclera. Tumors, very important. Most sensitive tumors, remember, Wilms. So these are all very hypercellular tumor. Wilms tumor, Ewing sarcoma has been asked. Lymphoma and leukemia are very cellular. M for multiple myeloma and seminoma. So all hypercellular small round blue cell tumor. But the ones that don't respond are HOMP group, Wilms and HOMP. HCC, RCCs resistant. Osteosarcoma, most radio resistant, PYQ. M, don't mix M, is melanoma, and P for pancreatic cancer. So melanoma, M, multiple myeloma, M is sensitive, right? So this is HOMP and Wilms. And the last thing, inverse square law, where intensity is inversely proportional to square of distance. So many times they've asked this. Means if this is the source of radiation, as I keep going away, the intensity decreases by a square. Alright, so this is all about radiology, very extensive, and this is all you need to answer possibly any question that I think can be asked. Everything else which is little extra, we'll do it with the MCQs. Alright, so I hope you enjoyed this video. Thank you so much.